بسم الله الرحمن الرحيم. الحمد لله رب العالمين، وصلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه أجمعين. سعادة وكيل الجامعة للدراسات العليا والبحث العلمي الأستاذ الدكتور محمد بن عبد الرحمن الشهري، أصحاب السعادة الحضور، ضيوف الجامعة الكرام، السلام عليكم ورحمة الله تعالى وبركاته. مرحبا بكم في صبيحة اليوم الثاني من مؤتمر جامعة المجمعة الدولي للسكتة الدماغية. بالأمس كان هناك جلستين، وتناولت الجلسة الأولى تطورات تشخيص السكتة الدماغية بمشاركة 4 متحدثين، وأيضا كان هناك الجلسة الثانية والتي تناولت مستجدات علاج السكتة الدماغية والرعاية السريرية بمشاركة أيضا 4 متحدثين. وتخلل مساء الأمس ورقتين علميتين، الأولى مقدمة من وزارة الصحة والثانية مقدم من مدينة الأمير سلطان للخدمات الإنسانية. نستكمل اليوم الجلسات اليوم الثاني بالجلسة الأولى والتي تحمل عنوان إعادة التأهيل وتحسين جودة الحياة بعد السكتة الدماغية، وسوف تتناول عناوين عدة، منها ما بعد التشافي الحركي، الرعاية الشاملة للألم والتشنج بعد السكتة، وسوف تتناول أيضا الجلسة تقييم الإدراك الوظيفي بعد السكتة، وسوف تتناول أيضا دعم جودة الحياة طويلة المدى للناجين من السكتة الدماغية، وأخيرا سوف تتناول دور الفريق متعدد التخصصات في رحلة التعافي والجلسة سوف تكون بإدارة الدكتورة دانا بنت محمد اليحيى. فندعو مديرة الجلسة لبدء الجلسة.
السلام عليكم ورحمة الله. صباح الخير جميعاً. Good morning everyone, and welcome back to the second day of the International Stroke Conference, and it's my pleasure to chair this session for today, where we will hear a variable presentation addressing important aspects of stroke care, rehabilitation, and recent advance in this field. I would like to thank our distinguished speaker and attendants for joining us for today, and look forward for engaging and productive session. So please join me in welcoming our distinguished speakers, Dr. Abdullah Muhammad Al-Ahmari, Consultant Physician in Ministry of Defense, Prince Sultan Military Medical City, and Dr. Muhammad Al-Hizan, Associate Professors and Consultant in Neurocognitive Rehabilitation at King Saud University, and Dr. Saeed Ahmed Al-Ghamdi, Consultant Neurologist and Assistant Professors at King Faisal Specialist Hospital and Research Center. And the end by Dr. Saud Muhammad As-Sadoun. He's a physiotherapist at Ministry of National Guard Health Affairs. Welcome, doctors. We'll start our session today with Dr. Abdullah Al-Ahmari, and he's going to present Beyond Motor Recovery Comprehensive Care for Post-Stroke Pain and Spasticities.
السلام عليكم ورحمة الله وبركاته. صباح الخير جميعاً. في البداية أشكر جامعة المجمع على استضافتي وحسن الاستقبال والترتيب والتواصل. Today I will speak about Beyond Motor Recovery Comprehensive Care for Post-Stroke Pain and Spasticity. أحد يساعدني بس في هذه دكتور، تحبين تسوين هذه؟ Today I will talk first about post-stroke pain. My objective for post-stroke pain, introduction to post-stroke pain, prevalence and time course of post-stroke pain, central post-stroke pain syndrome, and summarize the evidence-based treatment option for central post-stroke pain. Stroke is a condition caused by impaired blood supply to the brain, and is often serious, has a serious and long-term effect on the survivor. Stroke is growing healthcare concern worldwide, and Saudi Arabia is not exception to this trend. Post-stroke pain, pain after stroke is a common symptom that is poorly understood by many practitioners, and it can be easily overlooked, or it can, because of the variable characteristic and concurrent comorbidities and impairment in cognition and communication. While pain can create its own disability by itself, secondary to decrease in the function and its effect in recovery on the patient. Central post-stroke pain. Central post-stroke pain refer to pain resulting from primary lesion or dysfunction of the central nervous system after stroke. In past, central post-stroke pain was attributed to thalamic lesion, but now it's associated with extrathalamic lesion. The prevalence of central post-stroke pain is between 8 to 35. The variation and difference in prevalence is due to variation in the inclusion criteria and definition of central post-stroke pain and timing of the studies. Age, in a descriptive study involving 27 patients of central post-stroke pain, they reported a relative young age of stroke onset. The mean age was 62 compared to the general stroke population, which is 72. There is a study by Anderson, however, found no disparities in the age between the patient that developed central post-stroke pain. Publication from Sweden reported a median age of 65 years at time of stroke onset, maybe unrepresentative the general population due to exclusion criteria of intellectual and communication difficulties. Pathophysiology. The pathophysiology of the central post-stroke pain is not well understood, but central disinhibition, imbalance stimuli, and central sensitization have been suggested. Clinical features. The most patients of central post-stroke patient develop pain within 6 months after the stroke onset, and the incidence decrease thereafter. The most common patterns is hemibody central post-stroke pain. May occur in absence of weakness. However, neurological deficits such as hemiparesis, ataxia, chorioathetosis on the affected side may be present in 60% of the patients with central post-stroke pain. The distribution of the pain in terms of frequency, arm, leg, trunk, and face. It can be spontaneous or evoked pain. Spontaneous, which is continuous or paroxysmal pain. Most of the central post-stroke pain patients complain of burning and other symptoms, including aching, laceration, shooting, squeezing, and throbbing. It's in isolation or in a various combination of the above symptoms. Evoked pain may be precipitated by nociceptive stimuli or nociceptive stimuli. Usually allodynia, hyperalgesia are commonly associated with the patient with evoked central post-stroke pain. Contralateral or ipsilateral. The sensory symptoms of pain after stroke usually contralateral to the stroke side. Recently, central post-stroke pain reported on ipsilateral. In those patients, the ipsilateral pain developed between 6 to 24 months of stroke, and usually associated with worsening of the contralateral side pain. And the ipsilateral symptoms were mild and without objective sensory deficit, and developed in the body part mirroring the greatest pain on the contralateral side. Clinical and radiological correlations. Stroke anywhere in the spinothalamic pathway in its cortical projection may result in central post-stroke pain. Although in past thalamic pain was synonymous to thalamic stroke, most of the central post-stroke pain patients have multiple lesions in the MRI, and many of these are unrelated to the pain. Ventro posterolateral thalamic nuclear lesion are more likely to produce hemibody pain, than other lesions. The most severe pain is more likely in the extremity with the supratentorial lesions and in the face with infratentorial lesion. Treatment, the pharmacological and non-pharmacological treatment of central post-stroke pain is challenging. As with other type of neuropathic pain, variety of neuromodulation, psychoactive medication have been found to be useful in treatment. While data supporting their use specifically with central post-stroke pain may be somewhat limited, a few studies have been performed and we will present it below. Regarding the pharmacological treatment, while most of the medication can be associated with sometimes adverse effects, and the role of the physician should include assessing which medication will be best tolerated by the patient, and based on the age and other comorbidity, and to ensure safe treatment and maximum medication adherence. Non-steroidal anti-inflammatory drugs or medication, because of the concern about using of such medication in a stroke patient, the evidence are limited all the time. Antidepressant medication, we have the amitriptyline, is effective and safe and well tolerated compared to placebo for treatment, but in other double-blind placebo-controlled studies showed limitation in prevention of central post-stroke pain. Other antidepressant is duloxetine, a randomized double-blind placebo-controlled trial published in 2022 by American Academy of Pain conclude that duloxetine can be effective in treatment of the patient with moderate to severe central post-stroke pain. Fluoxetine has been shown significantly to reduce pain in central post-stroke pain patient when started within 1 year of stroke. However, if it started after 1 year, it was found not to be effective. Anticonvulsant calcium channel modulators such as pregabalin and gabapentin are a popular choice for neuropathic pain in general. Pregabalin has the most testing medication for this category and have been used in placebo-controlled double-blind study in 219 patients. In this study, the drug didn't significantly reduce the mean pain score, but it improved the patient's reported sleep, anxiety, and quality of life. A more recent study evaluated the long-term efficacy of pregabalin in 103 patients with central neuropathic pain. Found 60 of these patients were diagnosed with central post-stroke pain. Among the central post-stroke pain, 50% reported at least 30% drop in the reduction in the pain. Other anticonvulsant gabapentin is often the first anti-epileptic medication selected in the treatment of neuropathic pain in general due to flexibility of dosing, relative affordability. However, the data regarding the safety and efficacy in central post-stroke pain remain limited. Carbamazepine currently considered as a second-line treatment because its side effect and including Stevens-Johnson syndrome and aplastic anemia. Other anticonvulsant lamotrigine have been studied in placebo-controlled double-blind study where it significantly reduced the global pain score in 27 out of 30 patients with central post-stroke pain. Clinical significant results were achieved at dose of 200 milligrams per day. Phenytoin and Keppra has been studied in limited sample studies. Corticosteroid, while methylprednisolone has not been studied in any prospective studies of central post-stroke pain, a retrospective study suggested some potential benefits. In this study, 146 charts of a person with a stroke admitted to the acute inpatient rehabilitation ward were reviewed, 12, which is equal 8.2% of whom were diagnosed with central post-stroke pain. Within this group, it was found that the patient receiving methylprednisolone had significantly reduced the pain score 1 day after starting the treatment and 1 day prior to the discharge. Ketamine, in an uncontrolled trial, 23 patients of central post-stroke pain were given ketamine of a dose of 5 milligrams every 5 minutes, a total of 25 milligrams. More than 40% of the pain relief were observed in 11 patients. Lidocaine, the effect of lidocaine was evaluated in randomized double-blind placebo-controlled trial of 16 patients with neuropathic pain, 60% of those patients having central post-stroke pain, concluding that may be effective in short period after central post-stroke pain. Opioids not recommended. The tramadol, only one class, 4 studies showed tramadol to be beneficial. I will skip this non-pharmacological because of the time. Post-stroke spasticity. Now I'll talk about post-stroke spasticity. My objective is to introduction to the post-stroke spasticity prevalence and summarize the evidence-based treatment option for post-stroke spasticity. Spasticity is a common complication of stroke that result in impairment and limitation in performance of activity and participation. It's often related to other motor impairments such as weakness, disorder in motor control, which magnify its functional impact of the spasticity. It's occur anywhere between 19% to 92% of stroke survivor. Its prevalence may be as high of 38 in one study 2002. Estimated the incidence and the prevalence vary widely, perhaps because of the difference in definition and clinical measurement of spasticity and a varying severity and chronicity of stroke. Treatment, the mere presence of spasticity is not enough reason to initiate the treatment. A thoughtful assessment of clinical picture and functional impairment is the first step in establishing management strategy, followed by treatment goal setting. Pharmacological and surgical treatment, systemic medication, various oral medication with different mechanism of action have been used to treat spasticity. The most commonly medication including baclofen, tizanidine, dantrolene, and benzodiazepine. Overall, the medication has a marginal effect because of the side effect. The common adverse effect is drowsiness and is dose dependent and tiredness. Regarding the recommendation about the oral systemic medication, it can be used for segmental or generalized spasticity, but may be associated with dose-dependent adverse effect. Selection of type of oral medication depends on the individual's circumstance and may include combination. This medication should be titrated slowly and to monitor the side effects. Botulinum toxin type A injection is widely regarded as treatment of choice of medical management of focal and multifocal spasticity. Multiple controlled studies and multiple meta-analysis studies shows dose-dependent effectiveness, a reduction of spastic muscle tone, improvement in passive range of motion and passive function, as well as in reduction of the care burden while handling the affected limb, both by single and repeated intramuscular botulinum toxin injection. The recommendation, botulinum toxin injection therapy should be considered for post-stroke spasticity that does not sufficiently respond to non-pharmacological treatment. In these cases, it should be entertained when the therapeutic goal is to support passive function, like prevention of contracture, hygiene, washing, dressing, and can be used in selected cases to support active function. Neurolysis, nerve block with a neurolytic agent like phenol and alcohol are effective in managing focal spasticity according to study in 1988 and study in 2000. The recommendation phenol and alcohol neurolysis can be considered for clinically relevant post-stroke spasticity that does not respond to non-pharmacological treatment when the botulinum toxin injection is not feasible. The possibility of long-term unwanted side effects, especially neuropathic pain following the mixed nerve injection, need to be taken in account. Baclofen pump, intrathecal baclofen pump can be considered for clinically relevant severe segmental or generalized post-stroke spasticity that does not sufficiently respond to interventions. ITB treatment need to be tested, initiated, adjusted, and monitored with long-term support, including the emergency workup when indicated by a physician experienced with that type of the treatment. Surgical management it's need in individual cases after careful examination of, by multiple professional teams and after exhaustion of reversible treatment option of spastic movement disorder. Surgical procedure may be considered as a treatment of option in chronic spastic movement disorder following the stroke. Thank you. وأعذروني على الإطالة. شكرا لكم.
Thank you so much, Dr. Abdullah. And now we will move on with Dr. Muhammad Al-Hezan. He's going to present for us the functional cognitive assessment after stroke.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. في البداية أشكر جامعة المجمعة على الدعوة وعلى إتاحة الفرصة لي مرة ثانية. كان لي الشرف أني شاركت السنة الماضية في ندوة السكتة الدماغية، ولي الشرف أني أشارك معكم اليوم في هذا المؤتمر. أدعو الله سبحانه أن يحقق الأهداف المنشودة له. طيب, we'll move on to English because I guess there are some non-Arabic speakers here, so I'll speak in English, inshallah. My talk here today is focused on cognitive assessment after stroke. And my aim, inshallah, is to attempt to convince you of the need for a new, updated approach that takes into consideration the ability of a stroke patient to perform daily activities and quality of life. That's really my aim, inshallah, today. So before we start, I just wanted to give a quick background on cognition and how it relates to occupational performance. When we say occupational performance, we refer to our ability to perform the daily activities that we occupy our day with. There are different categories of occupational or occupations. The main two, probably those of us who work in rehabilitation know activities of daily living, and they are categorized into two main categories: basic activities of daily living as well as instrumental activities of daily living. Now, traditionally, basic activities of daily living do not rely on cognition. In general, we only rely on basic cognitive capacities. So those with stroke mainly do not have problems with basic activities of daily living. We rely on what we call procedural memory. When it comes to instrumental activities of daily living, these are more complex, more challenging. They require more cognitive load. So when we assess cognition, we often use instrumental activities of daily living. So these are driving, shopping, cooking, different than some of the basic tasks such as dressing or eating. So just a quick background on what I mean by occupational performance. Now, cognition after stroke, there's many literature that talks about cognition after stroke. Obviously, up to 70% of patients may have a cognitive deficit after stroke. These are often existing even 3 years post-stroke. Literature is varied on what are the most common cognitive processes or skills that are affected. Some say executive function, some say spatial ability, some say attention and language. And for me, it really doesn't matter, because what matters is the impact of cognition on occupational performance. We have tools and assessments that enable us to actually identify where the main issue is, but the impact of these issues is what matters. Another thing that I also wanted to highlight is the impact of mild stroke. We know that mild stroke consists of a significant portion of those who have strokes. And often after a mild stroke, we see patients that have what we call mild cognitive impairments. And these mild cognitive impairments are manifested mainly in complex daily tasks. So sometimes in the clinic or in the hospital or in inpatient rehab, we don't see patients performing these tasks, so we often discharge them and say they don't have any issues. But when they go back to their daily activities and they perform these complex tasks such as driving, shopping, paying bills, etc., they see difficulties. And this is another reason why there needs to be a different approach in assessment. Now, when we talk about cognitive assessment, we often think about traditional neuropsych assessments. So those of us who work in inpatient rehab, they probably heard of the MOCA, the Montreal Cognitive Assessment. And such assessments are often used, and decisions are made based on these assessments, sometimes solely. And in the case of the MOCA, it's not even an assessment tool, it's a screening tool, but we use it to make decisions. Now, typical cognitive assessments, they're paper and pencil assessments. They're tabletop. They usually have requirements. They're supposed to be performed in a closed environment without any distractors. They are highly structured and standardized. They rely on psychometrics. However, they focus, or they claim to focus, on isolated cognitive skills, and they lack ecological validity. So when we say ecological validity, we mean the extent to which an assessment reflects daily life. The ecological validity of an assessment. The question is, does performance on these traditional neuropsychological assessments, do they predict performance in real life activities, which is what matters eventually to our patients? And the literature and research suggests that they do not. So there's a need for a different approach. And this need is not something that is recent. This is from literature from the late 70s. So if you look at Nasser, who's one of the more prominent memory scientists, he talked about and criticized traditional laboratory neuropsych assessments. And he mentioned there's a need to assess the application of these cognitive abilities and skills. And he also talked about the need to address naturalistic and everyday contextual factors, as well as the complexity and the multidimensional aspect of how we perform daily activities. If you look at the neuropsychology literature, Lasik, who has a very well-known book from even the late 80s, talked about the need for more ecologically valid assessments, which they refer to assessment of cognition in real life. So there are different questions that arise from these criticisms and this literature. One is, how can we focus on occupational performance in the assessment of individuals with cognitive deficits? Two, do we consider other important factors in the traditional assessment of cognitive function, such as environment or contextual factors? How can we ensure that we prepare our patients for success in real life performance, which is eventually what matters to our patients? So there's a terminology which is quite recent, which we call functional cognition. Functional cognition is defined as the ability to use and integrate thinking and performance skills to accomplish complex and everyday activities in dynamic, clinical, and community living environment. So when we speak about cognition in real life, we want to make sure that we are effective, so the person is able to do this task. We are efficient, because someone is, for example, someone is shopping and he's shopping for 2 items and he takes 2 hours to perform this task. He's not efficient. So we want to make sure that they are effective as well as efficient, as well as safe. And safety is highly related to cognition in real life activities, because a person who doesn't take his medication correctly may have a serious health impact on them. If a person is not able to decide while walking or doing an environmental task and falls, there's a serious consequence that's a medical emergency. So we want to make sure that these 3 factors are considered when we assess our patients. And they have to be done while performing a functional activity. So it's important to think about the contextual environmental factors. which is not existent in the traditional neuropsych assessment approach. So someone who performs a shopping activity in the shopping mall on the right is different than someone who goes to Al-Haraj, for example. It's very difficult. There are different contextual factors that make it more complex. So are we preparing our patients to do these tasks in real life environment with the variety of contextual environmental factors that exist? It's also important to consider some of the limitations of the inpatient evaluation. Sometimes our patients are able to do these tasks in our inpatient safe environment, and we make a decision that they're okay to go to their homes. However, we are not preventing false negatives. So a person goes to their home and they find that their home environment is more complex, is different, and if they have these mild cognitive deficits, these deficits show when the environment is changed, when there's a different load, when there's an increase in challenge. So functional cognitive assessments have many elements. They, first of all, use multiple cognitive processes during a performance of a real task. They consider the environmental demands. They take into consideration the complexity of the task, and they're also dynamic in nature. And how we do this is through real-world tasks with increased challenge. And I'll give examples in just a little bit on actual assessments. So this is typically done through introducing novel rules or unanticipated obstacles or problems within an activity. And they should require a person, in order for us to make the decision that they're able to perform after they go out in the real world, they have to be able to make decisions and choices. They have to initiate. We know this particularly in stroke and traumatic brain injury. Sometimes our patients are not able to actually initiate the task. They have to be able to solve problems, plan and solve problems, and generate alternative methods to perform these tasks. There are a variety of functional cognitive assessments. These are some of them: the menu task, the performance assessment of self-care skills, executive function performance tests, and many more. An example of a well-known and successful functional cognitive assessment is the weekly planning or the weekly calendar planning activity, in which we present to the patient an empty calendar, and then we give them certain rules and certain activities to plan within this week. We make the task complex by giving them certain limitations. So we say, for example, leave Wednesday empty. We also tell them to tell the examiner certain type of information after a couple of minutes. We also try to distract our patients, because that happens in real life. We try to ask them questions that are not related to the task. And there's a scoring method, and this is also psychometrically sound as well as clinometrically sound. Clinometrics is another approach that I think clinicians should consider, which refers to the way an assessment is reflected and used within the clinic. We don't just consider the validity and reliability. We also have to consider the clinometric value of these assessments. So this is one approach. Another approach is the multiple errands test, which is an actual test where we ask the patient to do a variety of different tasks within a hospital lobby with limitations. We actually tell them to go buy something, to mail something, so on and so forth. So these are the approaches that are quite different from the somewhat sometimes limited neuropsychology approach that I mentioned earlier, which we're all familiar with. This is also an example of the menu task. I don't think we have time to show the video, but if anyone who's interested in the menu task, they can scan this QR code. And the menu task is a screening tool that I personally worked on during my PhD. And it was designed to be used in acute and post-acute settings. The gap that we found in the clinic was that clinicians are not able to perform these tasks within this limited environment. So we wanted to design something that reflects functional cognition, but is easy to use and quick to use. So this is, it emulates a hospital menu with certain limitations and rules that the patient is supposed to follow. Now, functional cognition is a new construct that is building literature to support, and anyone who's interested may refer to this book. I have a couple of chapters in this book, and it's a good reference for those who are interested in this construct, and anyone who's interested in cognition in real life. And those who are interested can email me. Inshallah, I can email them a copy of the book as an author. يعني. ما في تلاعب هنا إن شاء الله. So, thank you very much. Please email me if you want.
Thank you, Dr. Ray. Thank you very much. Now the time with Dr. Saeed Al-Ghamdi, and he's gonna present with supporting long-term quality of life for stroke survivor.
بسم الله الرحمن الرحيم. طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. ثاني مرة أكرر الشكر والامتنان للدعوة الكريمة. فالله يعطيكم العافية. So do I just click something here? It will show up? أيوة خلاص. Learning objective. Okay, we're good. So I'll talk as a clinician, as a stroke neurologist. I don't have the expertise or skill to go in depth on the rehabilitation process, but I'll talk about what I found in the literature probably effective, and then we probably during the Q&A period we can ask those who are really doing the job day to day, whether from rehabilitation, whether it's occupational or psychological assessment or cognitive assessment, as Dr. Sultan said, they can probably have more insight on any of these. So I'll try to distinguish between what is a quality of life versus health-related quality of life factors after a stroke. What are the drivers that can reduce the burden on these health-related quality of life aspects? And if there's any evidence-based intervention I was able to find in the literature, and if these evidence can be translated into practical steps that we can take in our daily clinical practice, especially here in Saudi Arabia, considering our culture, our resources, which is probably still limited in this aspect. So the quality of life factors implicate a general term that apply to health-related and non-health-related. So if you live in a country where has a good economical status, it's something that will affect your quality of life. If you live in a country with a great weather, it's something that probably going to affect your quality of life measures. But when you speak specifically about health-related quality of life, which is our main drive today, the health-related quality of life, you're being more specific to things that reflect on disease and its burden on the patient, like does the patient have pain or not? This is the health-related quality of life. Does the patient have anxiety, depression or not? This is also a health-related quality of life index or measure. So that's the difference between quality of life in general and health-related quality of life measures. So the common driver that will reduce your health-related quality of life can be various. It could be neuropsychological because of depression, anxiety, just being sad about whatever happened in this case. We're talking about an ischemic stroke or a stroke in general. How this event, clinical event that happened, which is in this case a stroke, how did it affect your ability to walk, to use your arm or leg? How did it affect your ability to communicate, to talk to your family, to talk to among your peers in school or in your job? If it does produce any symptoms specific like pain, fatigue, poor sleep, how did it affect your engagement in your society? Some people are quite heavily engaged in their society, whether it's a teacher, whether it's a Sheikh Jama'a, whether he is someone who's a public speaker. So an ischemic stroke or a stroke in general can have a huge burden in his participation within his community. And how does this all fill in within the context? In terms of the caregiver, here it could be a wife, a husband, a daughter or son, or a father sometimes. How does this probably going to affect the home environment after the event? Do we have to do some adjustment to the home after the patient gets a stroke? And what are the resources the hospital itself, the family, the caregivers can give, and the government can support the patient with? So there are many scales in the literature that can address these health-related quality of life, and most of them are patient-reported outcome. It depends on the patient, he or himself, so they're quite subjective, depending on what he or she says or feels, rather than being objective and rather being an assessment of the clinician or the healthcare provider who's doing the assessment. These are many examples of these related patient-reported outcomes that we can look into. So the international classification, it's a WHO definition, which is called the International Classification of Function, Disability, and Health, define that these health-related quality of life measures can have an effect on body function. As I give an example, moving an arm, moving a leg, able to walk, able to stand, and then probably going to have an effect on your activity, and then probably going to have an effect on your participation within your close family or then the community. So one thing drives to the next, and one thing does certainly affect the next for sure. And as Dr. Sultan said, we have to take this within the contextual factor. How does this going to affect your home environment, mode of transportation within the community, even your finances, and how much time and effort your caregiver has to spend with you. And this is something we don't really address very well in our day-to-day clinical practice, because we are focused on signs and symptoms as clinicians, but we don't focus on the caregiver who's looking after our patients. And sometimes we block their ability to help, and I'll give you good examples. I hope I can remember this. So the principle to maximize the impact that we can give in the health-related quality of life has to be patient-centered, has to address the patient goals. So we have to understand the goals, what are the most important things to the patient and or caregiver, has to address the mood, fatigue, and pain, because with pain, with very poor mood, with excessive fatigue, the level of engagement you expect from the patient will be probably poor, so you have to address these. And whatever intervention we provide, it has to be in a sufficient dose and in a sufficient, and in a progressive scale. So we can start low frequency, low intensity, but as we get going, we have to go further and further. And when we talk about intervention, then we talk about resources, which is the main limitation we have, bottleneck we have, is resources. I've throughout my career, I worked with excellent, outstanding healthcare providers from occupational therapy, speech-language pathology, and physical therapy. They're excellent. They're very well trained, but we always have the bottleneck. They are very, very few compared to the number of patients they have to serve. So at the end of the day, they're not giving the patient what they need. And then maybe with this limitation of the resources, maybe the technology now can help with virtual reality exercises and with tele-rehabilitation session. Whether or not this is evidence-based or not, probably the expert can tell us if it does help or not. So I'll give some examples of the interventions that tackle the care transition, intensity, and participation. So early supported discharge. So your case management before even the rehabilitation team are engaged, the case management working in your hospital or your facility has to be engaged early as soon as the patient shows up with a poor swallowing. So a swallowing assessment should be done early. If the patient comes in with a severe stroke that we anticipate the patient will not be able to walk or move in the next few months, maybe for life, this is not something that you leave to the last day, say to the family, we're done, there is no further medical intervention we can give, discharge. It's quite easy for us to make this clinical decision, and it's an appropriate clinical decision. But for the family, definitely it's not appropriate. They are not prepared, they don't know what to do, they have many limitations at home, so this has to be addressed with case management if you have this service in your hospital. And it should happen from day one, from the day the patient arrived to your hospital. And then we should establish some sort of transition program from the hospital to the home and then to the community. And this probably definitely engaged the family members, but also our home healthcare team, which can include rehabilitation services as well, nutritional services can help in that. And again, whatever we decide on every single patient, it shouldn't be a stigma that we use for every single patient. Every single patient, we have to study him or her and decide what are their best goals that are attainable, that we can do, and that for them it's of huge interest. For the physical rehabilitation, the interesting thing I found some new literature in is definitely the typical physical therapy we do, but now there is some robotic assisted devices that even can help engage training. I think I have a photo. This is an interesting photo I found in the literature, and there is some literature on it, which is a robotic assisted device that can help the patient stand and maintain stance and gait as well. So these are measures that probably can help and going to take huge impact in the future on those measures. And the other thing for the upper limb weakness, the constraint-induced movement, so you constrain the functioning good arm to push the affected arm to be engaged more and more and be engaged in the rehabilitation program the physical therapists use. And some also robotic assisted therapy might be an intervention that we look into the future. And the virtual reality. Virtual reality can help in creating the environment. I don't think it's going to be the ideal, but if you want to create the 3D environment for occupational therapy program, and then you are quite limited in resources, maybe visual reality, and I don't think it's going to be the best approach, but maybe it's an alternative you can think of as well. Although, for me, it's a big headache. I can't believe that I have these goggles and looking into 3D things and moving around with it. I definitely will have this, what they call cyber sickness. And then telerehabilitation. And the hospital I used to work with, when Corona did hit, they established this through iPad, and I wasn't engaged myself in it. But the feedback I got from the patient when I saw them after, they were quite happy, especially with speech-language pathology and with occupational therapy. It was quite limited in physical therapy, but they were happy with occupational therapy telerehab, and they were happy with speech-language pathology telerehab because of the limitation in movement during Corona. The spasticity management, probably I'm not going to touch on that. Previously it was mentioned, there are many drug intervention and physical therapy intervention for spasticity. The most famous one is baclofen, and then you have Botox as well, injections, and some assisted devices for the occupational therapy. I'm not going to touch on that. In the mood cognition, we should address any mood issues. We should address if the patient just need a psychological intervention or a drug intervention with antidepressant or anti-anxiety medication. That might be something that we should consider, at least for a transition during the first few months after the stroke, to help him get engaged and motivated in his rehabilitation journey. So cognitive rehab, I think after what Dr. Sultan said, I have really limited things to say. other than emphasizing the great points he mentioned in his talk. Fatigue is a major issue, and unfortunately, the medical intervention we have is quite limited. The medication we give, from my limited experience, it's not quite good and it doesn't help much. So other than engaging in physical therapy and improving the psychological well-being of the patient, I'm not very keen about giving medication to address the fatigue. Pain management, it was mentioned previously in great points, so I don't have to address that anymore. And the aphasia and the language deficit with a specialized speech-language pathologist, and maybe with the help of, because there are quite limited number of them, very limited throughout the country. Even in big cities like Jeddah, Riyadh, there are very, very few speech-language pathologists available for service. So maybe this is one of the domains that tele-rehabilitation might function very well. And the dysphagia assessment also with speech-language pathology should be done as early as possible and then addressed. And the patient himself, he or she should be engaged, as I said earlier, in their goals and what they want and then what they don't want. This is the thing I want to address, the caregivers and how can we support them. From the rehabilitation perspective, so there is a patient who had a stroke, then his wife, there is a patient, there is his daughter, there is a patient, there is his son who's want to be engaged and want to help. And what I find, interestingly find, and we quite get hooked up in a game whether they want to take advantage of us or not. I'll give you a good example. So a patient with a massive stroke comes in and his wife is a teacher, mudarrisa. So she comes to you, she says, well, you see the condition of my husband, he's going home with me, I want you to give me اللي هو الإجازة المرافق. And I think it should be straightforward, yes. But we get into the clinical practice, some of my colleagues, they go into the game of are they taking advantage, is she really taking care of her husband or not? This is not our business. Our business is that she is the primary caregiver. She asks for this. Whether she does it or not, هذا بينها وبين الله سبحانه وتعالى أو بينها وبين المؤسسة اللي تشتغل معها. It's not our job to decide, oh, she's doing it or not. And we are legally bound, we can do it. There is no repercussion on us. She deserves this leave, just go and give it. It happens also to a son or a daughter. Then, I'm not saying be naive, that you can have a patient and he has 3 or 4 sons. All of them come ask for this leave, I will not give it. Probably choose 1 or 2. But we have to do our best to help and empower the caregivers to take care of their loved ones. And I don't want to keep going further. This is a good example that we see in clinical practice. The other thing, one of the major bottlenecks is not the quality of the healthcare providers we have, especially in rehabilitation, it's the number. And this is something I don't feel we're advocating for, even in big medical cities or hospitals. We see that big hospitals and big centers like our center, the headlines goes to the robotic surgery we did, to the major intervention that no one else did. But what really added value to the community is that care, as simple as it is, even if it's a physical therapy, which seems simple, it should be delivered in the best time and dose to those patients who need it. We find we take a huge investment on that level, but we don't take as much investment on these simple things that we're probably still quite short on it. So I think we have to invest more in rehabilitation as much as we are investing in the clinical part. With this I conclude. جزاكم الله خير. شكرا لكم جميعا. السلام عليكم.
Thank you, Doctor. Last but not the least, in this session, it's going to be with Mr. Sadoun with the title of Multidisciplinary Roadmap for Stroke Rehabilitation.
Assalamu alaikum wa rahmatullah. I want to thank Majma University for this invitation, and I am proud to be here again with my teachers and colleagues. Our topic today is the role of multidisciplinary team and recovery journey of the stroke patient or rehabilitation journey. We know from yesterday and today that the stroke impact the body system stimuli and affect the motor, cognitive, speech, psychological, and social functioning for the patient. And there is no single discipline can treat the stroke complex impairment or complex functional level dependency. And we know that the MDT care can reduce the disability, improve the quality of life, and also accelerate return to the independency, or at least the levels or previous functional level before the stroke. We want to talk about the core discipline of stroke rehabilitation team. We know the physiotherapist, we are responsible for assess and treat motor sensory impairment, also a cardiovascular limitation of the patient. Our role also exceed to reach the caregiver, like Dr. Saeed mentioned before. We are responsible also to educate and train the caregiver to take care of the stroke patient. Our colleagues, occupational therapists, are responsible for ADLs, IADLs assessment and treatment. They also have a great role in cognitive assessment and rehabilitation. In some cases, also occupational therapists help in visual rehabilitation. Our colleagues from psychologists, actually they have a great role, especially when we treat patients with depression and anxiety. And we can see this with geriatric stroke patients. They also can help us to engage the patient to participate in the rehabilitation process. Our physiatry, our colleagues from BMR, they are leading the process. They have a responsibility on medical care of the patient. They help also to follow up with the goals of the patient and managing the medical complexity of a stroke patient. The speech-language pathologists, they mainly focused on the communication disorders, swallowing, and also help the occupational therapist in cognitive rehabilitation. And we know the nurse, there is no MDT without nurse, so they help to take care of the patient daily life. They help on medication. They help also and engage the patient in the rehabilitation process. The social worker help us also in social support for the patient and the patient family. So the always on MDT or collaboration between the MDT member, they are doing a regular meeting like a conference between the all MDT member. This conference always been done as a weekly basis. They review the patient goal. They also assess the patient improvement, and they set the plans for the patient, unified goal setting and care coordination as well. We have a lot of research in the literature actually supporting the MDT approach. This stroke unit trial collaboration is a meta-analysis of 28 trials, more than 5,000 patients. It's concluded that organized stroke unit care, 18% relative reduction in death dependency among stroke patients. There is also benefit persist as a long term regardless to age 6 of stroke severity. And the recent study, 2020, conclude that the coordinated MDT rehabilitation improve ADL performance, early intensive task-specific therapy yield best outcome, and patient-centered goal setting enhance engagement and satisfaction. The measuring the impact, the key outcome on MDT rehabilitation, there is a 62% discharge to home versus 43 non-MDT setting. There are also 8.5 day shorter length of stay among the MDT rehabilitation setting, and also 40% readmission reduction within 3 days post-stroke. When it's come to patient satisfaction, there is 4.2 average rating out of 5 for the MDT care when they compare with the single disciplinary care. We know that there is no rehabilitation or no rehabilitation process without family support, and we experienced this before. The patient with a good support from family, they recover better, faster, and well than the patient without family support. So we always engage the patient in shared decision making. Patient and caregiver actively participate even in goal setting with the patient. We have a responsible role toward the patient, family, and caregiver in empowerment, education. Also, we provide, or the MDT provide, the caregiver support, like in a handling technique with a stroke patient. We know stroke affect the patient. Sometimes this patient will live with a disability for a long term. So handling technique, communication strategy, also empower the patient to participate in rehabilitation process and home exercise program, for example. Like everything, we have a lot of barriers regarding to the MDT care and how this barrier affect the implementation of the MDT collaboration. We know the communication gap between the teams. It's more than 6 members or 6 teams, so always there is a communication gap. Also, there is a resource constraint, like some hospital cannot provide the equipment or cannot provide also the best EHR system or HIS system that help to support rehabilitation process. We have also a fragment system, an acute rehab community transition, lack of information also. So the barriers is actually between, it's on 4 or 3 factors, sometimes patient factor, sometimes facility factor, and also the therapist self factor. Also the variable training, there are variable training between disciplinary or between hospital, so this make the rehabilitation process or MDT process or collaboration a little bit harder. So I put this solution, it could help on building a good multidisciplinary team and stroke rehabilitation, like establish a good protocol. A good protocol make everything clear. It can help to make a clear plan between the team and everyone know what can they provide, what can they give the patient to help him and his functional limitation. The technology, nowadays it's better to invest in the technology rather than the old method we used before. So foster team culture. The team culture is important, and we experience this a lot. In a lot of hospitals I worked before, a good team communication, it's mean a good rehabilitation outcomes. Also the measurement and improve the measurement, the outcome, it could help to address the quality cycle and the quality improvement. Also engage the leadership on this process will help to build a good MDT team. The gold standard for stroke recovery when it's come to the MDT, comprehensive care. MDT address multi-factored needs actually for stroke survival. Evidence-backed collaboration is the key. Continuous improvement. We know that each 4 or 5 years the evidence change. We are not doing what we do before 5 or 6 years. So the continuous improvement is a great key or a great tool, help to collaborate this MDT team to get good functional outcomes. At the least, but not least, the whole is greater than the sum of its patient. Multidisciplinary collaboration actually help the patient to regain his functional level, and together we can optimize the recovery for a stroke patient, and we can really help him to participate in the community. And this call for action, actually, we hope from all university or stakeholder to invest in MDT collaboration to have a good impact on our stroke patient. And thank you.
Thank you, Mr. So this brings to us that conclusion of these sessions, and I would like to sincerely thank our distinguished speakers for their valuable presentation and thank for the audience for their attention. Now we will open the floor for the questions and discussion. You can start.
Do you have any challenges or rules to escalate this project which will help the kingdom in the future participating in the establishment of any future projects? You can just add to us so we can get benefit from your information. Thank you so much.
I know nothing about what you said. ايش اسم البرنامج؟ برنامج ايش؟
مستشفيات الرعاية المديدة هذا الآن الوزارة
الرعاية الممتدة.
الرعاية الممتدة.
لا هذه موجودة، أنا آسف، السيرفس موجودة بجدة.
يعطيك العافية على السؤال. طبعا في نقطة مهمة انه ستروك تريتمنت اذا ما تكمل بريهابيليتيشن ترانزيشنز ما تكمل التريتمنت يعتبر. لانه الستروك ريهابيليتيشن اذا ما كانت تسوت خلال 6 شهور الاولى من الستروك يعتبر المريض فقد جزء كبير من التريتمنت بلان حقته. فهذه للاسف انه اغلب المستشفيات عندهم they invest في الستروك يونت وفي التكنولوجي بس ما they are not invest في الريهابيليتيشن يونت. acute rehabilitation units post stroke should be in every hospital. The patient should have a transition to a rehabilitation facility immediately after stroke treatment, second day after stroke بالجايد لاين. للاسف اغلب المرضى ستروك يعتبرون long term شو اسمه patient, they are not long term patient. لو حصل على rehabilitation جيد خلاص وهذا يفرق لان انا اشتغلت في منشآت عندها acute rehabilitation unit وفي مستشفيات ما عندها acute rehabilitation unit. المستشفيات الاكيوت ريهابيليتيشن يونت اغلبهم يرجعون حياتهم طبيعيه او شبه طبيعيه وما يحتاجون لونج تيرم، بينما المستشفيات اللي ما عندها ريهابيليتيشن يونت في الغالب المريض ينتهي انه يروح الرعايه المديده او لونج تيرم فاسيلتي، وهذه صراحه نقطه كبيره لازم الجميع يتحدث عنها، لان التريتمنت ما تكمل اذا ما نقل المريض الى الريهابيليتيشن خاصه اذا كان عنده فيزيكال ديسابيلتي. هذا هو النقطه اللي عندي.
انا بس اضيف على كلام الدكتور عبد الله، انا اعتقد ان اصلا ايديلي ان المريض ما يروح للرعايه المديده، هذا المفترض يعني زي ما تفضل الدكتور. الاشكاليه اعتقد المنتشره عندنا ان المريض ينتظر لفتره طويله للحصول على التاهيل اللي هو الانبيشنت او السيرفيس البروتوكول باكمله، حتى لما يكون في الاكيوت ستيج ومو ميديكالي كلير فور ريهاب لابد يكون في كذلك engagement من الريهاب بروفيشنالز اللي تسريع ويكون الريكفري في كفاءة أعلى. فأنا أعتقد أن من الأساس مفترض مرضى ستروك نسبة قليلة ضئيلة جدا هم اللي ممكن ينطبق عليهم الوصول إلى الرعاية المديدة من الأصل، لكن الواقع اللي احنا نعيش فيه إنه في كثير مع الأسف راح يحتاج رعاية طويلة الأمد خلينا نسميها، بعض الأحيان تكون في المنزل أو في الكوميونتي بيست سيتنجز أو الخاص أو الآن المستشفيات اللي بدأت الآن تنشأ اللي هي في الرعاية طويلة الأمد زي مستشفيات مديدة عندنا في حرم جامعة الملك سعود. في سياق الإدراك أنا أعتقد أن الرعاية الممتدة لازم يكون فيها continuous assessment، والcontinuous assessment هذا لازم يركز على الاسبكتس اللي تهم المريض او تهم الكير جيفرز، فالفانكشنال cognitive assessment والapproaches اللي ذكرتها اليوم أعتقد أنها تؤثر بشكل كبير في الرعاية، نوعية الرعاية ومدى الحاجة للرعاية الممتدة هذه، وكذلك الأشياء المتعلقة زي ما ذكرها الدكتور سعيد بالhealth related quality of life. إذا حنا حطينا ICF موديل في الحسبان أعتقد أن كثير من المرضى اللي ممكن يدخلون الرعاية المديدة هذه خاصة after stroke أو neurological conditions ممكن حاجتهم لها تكون أقل بكثير أو تكاد تكون عدم موجودة.
Thank you, doctors. Any other question?
Thank you very much for very important presentation. My question is for Dr. Muhammad Al-Hizan about using neurocognitive assessment for stroke patients in Arabic. As we know, what we study is it's all in English, MOCA protocol or studies, or the paper they use it. It's totally different than our the modalities what we have in Saudi Arabia. How can we use it in Arabic and how can we reach it? Like to assess our patients for in Arabic, or do we have version Arabic specific for our patients in Saudi Arabia? And the other question for Dr. Saeed, we know you work like one of the distinguished strokologists in Saudi Arabia, and you work in two big centers, National Guard and King Faisal Specialist Hospital. Is there any programs they use AI or robotic or like any other technology for stroke patients care, either in acute or post-stroke service? Thank you very much.
سؤال مهم جدا يا دكتور ولمست الجرح يعني. I'll answer in English since you asked in English. Yeah. In cognitive assessment, one of the main challenges that we face, I would say, is translation. In neuropsychological assessments that are quite limited and structured, having a translation that is fusha may work. However, when we talk in the context of dynamic assessments, so some of the assessments that I've shown today are quite dynamic, so they require interaction between the assessor and the patient. How can we make it natural as well as structured and standardized and valid and reliable when there is a chance for variability in the mode or the assessment? So essentially what I'm saying, I cannot make the assessment purely fusha. So when I'm asking a patient, just to give an example, can you do so and so? In fusha, هل من الممكن أن تفعل كذا وكذا؟ ممتاز. However, in the dialect, in Arabic, there are different dialects. There's the Najdi dialect, there's the Hijazi dialect, and even if you expand it to the Middle East, you know, when I started translating and I found this major issue, I was hoping that these assessments will be used in anywhere in the Middle East. That was my plan. And then I found that it's possibly not that easy because there are different dialects within our own country and beyond. So I think that's a major issue. One solution that I'm thinking about, you know, trying out, and this is obviously a research study as well, is to sample these assessments. And there's an interaction, let's just remember that, because if the patient, some of these assessments, if the patient performs incorrectly, I'm supposed to say something. Some of them require cueing. So in English we say, are you missing something? Can you try a different way? So in English, in Arabic, what can I say? In Najdi, there's probably going to, ممكن تجرب طريقة ثانية. الحجازي ممكن ما أدري عاد ما نبي بقلد الحجازية يعني عشان ما أفشل نفسي هنا. لكن this is a major issue. This is a major issue that requires studying and also establishing is dialect an issue in the administration of these assessments, and can we rely on fusha alone in making it natural as well as psychometrically sound and standardized, meaning anyone can use it regardless of where they are. but it's a very good question. Thank you.
طيب بسم الله الرحمن الرحيم. بالنسبه للسؤال اللي يخص بتكلم بالعربي، اللي يخص يعني عملي في الملك فيصل التخصصي وقبلها في مدينه الملك عبد العزيز الطبيه الحرس الوطني. whether there's robotic وال AI has been already integrated في الريهابيليتيشن I'm not aware of، بس الدكتور سعود الله يحفظه ان شاء الله بيعطينا خبر اذا شاف شيء في الحرس عن طريق الريهابيليتيشن. في الكلينيكال داي تو داي براكتس يس، الحرس في الرياض قبل فتره جاب روبوت تو موف اراوند، يتحرك كذا من الطوارئ الى الى الاشعه، بحيث ان الدكتور في البيت كان نافيجيت الروبوت يروح المريض وعليه كاميرا ويتكلم معاه وياخذ ويعطي عشان يتخذ قرار سريع في اعطاء الدواء مذيب الجلطه ولا لا. طبعا استخدم اعتقد ايام او شهور وبعدين بطلوا، لانه in my opinion it did not have any added value. It was something that looks nice but it didn't make any difference في patient outcome في decision making. الان التخصصي بدا عندنا يعني زي ما تقول بايلوت ترايل، قاعد يجرب برنامج AI شويه مخيف بالذات للجيل القادم من الاطباء. في برنامج AI وانا جربته اوريدي في مستشفى خاص في جده. في برنامج AI في مايك قدامي على الطاوله في العياده، يسمعني ويسمع المريض، والمريض فعلا يتكلم بمعظم اللهجات. يعني جوني مرضى في العياده الخاصه القطاع الخاص، يجينا مرضى من مصر من الشام من السعوديه من كل مناطق المملكه، يسمع المريض ولما يطلع المريض بس يضغط زر ويلخص كل اللي قاله المريض، وغالبا تلخيص كويس تعديلات بسيطه، وبعدين يلخص اللي انا قلت عليه انه وجدته في الفحص السريري. والتخصصي جايب برنامج بياخذ ستيب زياده، هذا المخيف انه مو بس بيلخص هذه الاشياء، بيعطينا انطباع، يقترح يقول المريض غالبا عنده كذا وكذا وكذا وسوي كذا وكذا وكذا. فبعدين تصير تسال نفسك وش ما صار في داعي للدكتور. فهذا لسه التخصص الحين بادي عليها بايلوت يجربها يشوف هل هتشتغل ولا لا، فلسه ما عندي خبره فيها. بس في القطاع الخاص جربتها، شيء مخيف يعني فعلا يسمع المريض يتكلم 5 دقائق بعدين يلخصها بكلمات طبيه ساوند ميديكال تيرمز. يعني بقول مثال، يعني في ضيقه نفس يكتبها the patient complained of dyspnea medical terms. وكان البرنامج مستوعب معظم اللهجات اللي جتني، سواء من مصر من الشام، جاني ناس مرضى من السودان، جاني مرضى من السعوديه، مستوعب جميع اللهجات، وكان جد يعني مو دقيق بس دقيق لدرجه عاليه جدا. لكن في الريهابيليتيشن الاخ سعود يمكن افضل مني يقول اذا في الان دخل الروبوتيك والاي اي في الريهاب.
للامانه الروبوتك داخل عندنا في الريهاب من مده طويله، بس الاي اي الى الان موضوع جديد على الثيرابيست وجديد على البيشنت وجديد على
احسن لكم والله.
لكن ان شاء الله الاستاذ محمد الحربي واستاذ ابو اسامه بيتكلمون عنه ان شاء الله بشكل اوضح.
الله يوفقك.
Thank you so much. I think our time is already done. So thank you so much for the speakers. And now we will move on to the first scientific paper presented by Dr. Taysir Al-Mutayri, maternal fetal medicine consultant, and she's associate professor in the Department of Obstetrics and Gynecology with the titles Cerebral venous sinus thrombosis in pregnancy and the postpartum period incidence, management and maternal mortality outcomes, a systematic review and meta-analysis. Please welcome to Dr. Taysir Al-Mutayri.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. أولاً I feel a pleasure to present today with our colleague from neurology, physical therapy, dentist, and I will speak from obstetric gynecology point of view. So my talk today is about cerebral venous sinus thrombosis in postpartum and in pregnancy will speak about management and maternal mortality outcome. This is a systemic review meta-analysis studies was registered before Prospero. We have registration number for this study. So in the beginning, as we know, cerebral venous sinus thrombosis is rare in pregnancy, but severe, causing cerebrovascular disorder, disproportionately affecting women in reproductive age. Pregnancy and postpartum, we know, is a high-risk window to develop strokes and cerebral venous sinus thrombosis because the status of hypercoagulability in a pregnancy We know in the pregnancy the clinical representation is heterogeneous because we know in the pregnancy all the patient can come with headache, which is like normal in pregnancy. So the symptom is ranging from isolated headache to major neurological deficit, seizure, and in some cases intracranial hemorrhage. In recent guideline endorsed, the anticoagulation is the cornerstone for management. Even in selected cases with hemorrhage, they use anticoagulation. However, substantial variability persists in diagnostic rigor, anticoagulation timing and duration and intensity across care setting. This is what we found it as an knowledge gap. We don't have longitudinal reproductive safety and thrombotic recurrence risk due to prior CVCT remain insufficiently because all the study is short-based hospital study series. So that's why we go for long-term cohort study. So our aim, we stratified our patient into two populations to synthesize, our aim to synthesize a cohort evidence on maternal and obstetric outcomes in pregnancy associated with cerebral venous sinus thrombosis and in women with prior history of cerebral venous sinus thrombosis undergoing to subsequent pregnancy. Secondary objective, quantify recurrence risk through the pregnancy if she had a history of CVCT. Estimate pooled maternal mortality in cases of acute cerebrovascular venous sinus thrombosis. And characterize anticoagulation uptake and practice variability. Our review would follow PRISMA protocol, was previously registered in Prospero, and we have PICO-based eligibility specification to ensure reproducibility and transparency. We have a population for two populations who had previous affected with cerebral venous sinus thrombosis women or women who had acute event of cerebral venous sinus thrombosis through pregnancy. Exposure, the disease itself, which is the cerebral venous sinus thrombosis. The outcome will look for mortality rate, recurrence risk, and our study is cohort type studies, long cohort type. So we use, in our study, we search a systemic search, we do systemic search through 6 major databases, PubMed, Medline, Embase, and Cochrane Library and some trials. And we use, in both, we use controlled vocabulary and free text terms to search to capture the studies in cerebral venous sinus thrombosis, in pregnancy, preperium, and postpartum. We exclude all the studies, short studies like case report, serious, insufficient follow-up for patient, we remove it, excluded, and non-extractable data. Risk of bias, evaluate, we do a clear attention for participant selection and confounding control and consistency of outcome measurement to ensure the risk of bias. So outcomes, we use to synthesize the as pool proportion using random effect meta-analysis, statistical heterogeneity by using I-squared and Y-squared and Cochrane Q test. Our population, as we mentioned before, were stratified the patient in two populations, as we mentioned, who had cerebral venous sinus thrombosis in pregnancy or who has history of cerebral venous sinus thrombosis. Sensitivity analysis for low event outcome, like as in recurrence, we use it. So this is our Prisma diagram, which is, we follow it in our process selection. We identify cases like, in the beginning, we identify by searching with the database, 864. We exclude the duplication, 109, before the screening. After screening, when enter the study with 755 recorded, we screen the abstract and title. We exclude 81, and we screen the 674, which for a screen for retrieval, 56 file not retrieved. And full text article were reviewed for 618 studies, and we exclude, as we mentioned before, in our eligibility criteria, we exclude the case report, case series, and review study, and animal studies. So we ended by 12 long cohort studies, which meet our criteria. So geographic representation is in Europe, North America, and Middle East, and Asia. As we mentioned, we note a long evidence-based maternal outcome, so we take a long duration period, 5 to 15 years, to ensure the good assessment for recurrence and the outcomes. So we choose more than 5. We ended by 5 to 15 years. As we mentioned, 2 distinct analytic population, the 2 population when we start, we defined. Which is a longitudinal pregnancy after cerebral venous sinus thrombosis, and who had a history of cerebral venous sinus thrombosis, and we will look for the outcome after that. And the ladies who had acute event of cerebral venous sinus thrombosis within the pregnancy. We ended by, among in the first population who had a prior CVST in subsequent pregnancy, after they getting pregnant, we had pool proportion live birth 69.9 with moderate heterogeneity, which is give us a good reassurance for our patient. If they have a history of cerebral venous sinus thrombosis, still they have chance to deliver without complication with a structural follow-up, because we need to give prophylactic and good follow-up. Regarding the rate of spontaneous abortion, we ended by pool proportion of 19, which is the same of universal spontaneous abortion percentage, and with the minimal heterogeneity. And the most important is the risk of recurrent of CVCT, the risk of having the same issue, which is a stroke again. It's very rare, 3.2 with no heterogeneity in all the studies. In the second population with acute event of cerebral venous sinus thrombosis in pregnancy or on postpartum, as we know, usually most the cases had this event on postpartum, more percentage than in pregnancy. But in the pool proportion in total, we measure mortality rate. In this group, we found it is very reasonable, 8.3, with no heterogeneity. And in anticoagulation use, we found more than 93 use with high heterogeneity. What that mean it's a lot of variability in giving the anticoagulation, variability in timing, duration, and in intensity, and of the type of duration itself across all the studies. So in conclusion, cerebral venous sinus thrombosis in pregnancy associated with high acute neurological mortality and long-term recurrence with structural follow-up. This is we ended by our end of the result. Generally, favorable obstetric outcome among all survivors, because the outcome of the ladies who have a history of cerebral venous sinus thrombosis, we have a good spontaneous alive babies, which is the percentages are reaching 70%, which is a reassuring number. And even the recurrence abortion, it's giving the same universal percentages, 19 in like international percentage. So it's from obstetric outcome is reassuring. Maternal mortality remain clinically relevant despite high use and variability of use of anticoagulation. This underscores need to standardize diagnostic reporting and integrate risk stratification by infection control, optimize blood pressure and anemia control, and targeting thrombophilia screening. Harmonized anticoagulation protocol across center to reduce variability. So our end outcome, our finding offer reassurance with vigilance. Subsequent pregnancies after cerebral venous sinus thrombosis are often successful with good percentage we have, yet acute obstetric cerebral venous sinus thrombosis still carries a measurable mortality risk, highlighting the need for standardized evidence-based management pathways. Thank you for your attention.
شكرا للدكتورة تيسير المطيري، وأيضا الشكر لمن تحدثوا في الجلسة الماضية بإدارة الدكتورة دانا بنت محمد اليحيى، والشكر أيضا للمتحدثين الدكتور عبد الله بن محمد الأحمري، وأيضا الدكتور محمد بن أسامة الحيزان، وأيضا الدكتور سعيد بن أحمد الغامدي، وأيضا الأستاذ سعود بن محمد السعدون. قبل الخروج لاستراحة قصيرة هناك سحب على الجمهور، وهي جوائز مقدمة من صندوق الطالب، وسيكون الفائزين من صيد الكاميرا. تفضل. بانتظار اختيار الفائز الأول. ألف مبروك. الفائز الثاني ألف مبروك. ننتقل إلى الفائز الثالث أو الفائزة الثالثة. ألف مبروك. ننتقل إلى الفائز الرابع أو الفائزة الرابعة معنا في هذا اليوم. ألف مبروك. ننتقل إلى الفائز الخامس أو الفائزة الخامسة معنا في هذا اليوم. ألف مبروك. ننتقل إلى الفائز الخامس أو الفائزة الخامسة معنا هذا اليوم. ألف مبروك. ننتقل إلى الفائز السادس أو الفائزة السادسة والأخير معنا هذا اليوم. ألف مبروك. استراحة قصيرة لمدة 20 دقيقة، نعود بعدها لاستكمال الجلسة الثانية من اليوم الثاني لهذا اليوم. شكرا لكم. العلمية لليوم الثاني من هذا المؤتمر. بإذن الله تعالى سوف تتناول الجلسة العلمية الثانية والتي تحمل عنوان التقنيات الحديثة والتطورات الطبية في مجال تأهيل السكتة الدماغية. هذا العنوان الأساسي لهذه الجلسة سوف تتناول عدة عناوين فرعية، منها الابتكارات الرقمية في متابعة وتحسين الأداء الوظيفي، وأيضا العنوان الآخر مستقبل التأهيل باستخدام الأنظمة الذكية، وسوف تتناول أيضا دور التحفيز العصبي في دعم التعافي، وأخيرا سوف تتناول هذه الجلسة التعافي الجذعي بعد السكتة الدماغية. سوف تكون هذه الجلسة بإدارة الدكتورة شريفة بنت محمد العسيري، فلتتفضل لبدء الجلسة.
السلام عليكم ورحمة الله، صباح الخير جميعاً. اليوم بإذن الله تعالى راح ندير حلقة حوار بعنوان التقنيات الحديثة والتطورات الطبية مجال تأهيل السكتة الدماغية، وأتشرف بالترحيب بالزملاء المشاركين في هذه الجلسة. سيكون معنا سعادة الدكتور محمد ناصر الشهراني، وهو طبيب استشاري ورئيس قسم الطب الطبيعي وإعادة التأهيل بمدينة الملك عبد العزيز بالحرس الوطني، تحت عنوان الابتكارات الرقمية في متابعة وتحسين الأداء الوظيفي. أيضاً سيكون معنا سعادة الدكتور محمد حسن الحربي، وهو أخصائي أول في العلاج الطبيعي ومدير قسم خدمات إعادة التأهيل بمدينة الملك عبد العزيز الطبية بالحرس الوطني. وسيكون معنا متحدثاً أيضاً سعادة الدكتور عبد الكريم سليمان الحميد، وهو أخصائي أول في العلاج الطبيعي ورئيس قسم العلاج الطبيعي في مدينة الأمير سلطان الطبية العسكرية. وأيضاً نتشرف بحضور الدكتورة نورة بنت عبد العزيز الهويمل، وهي أستاذ مشارك في قسم العلاج الطبيعي بجامعة الأمير سلطان بن عبد العزيز في الخرج. So good morning everyone. Today, inshallah, we will discuss in this session modern technologies and medical advances in stroke rehabilitations. We do have 4 speakers. Today we are very proud to have them with us. We do have Dr. Mohammed Nasser al-Shahrani. He is a consultant physician, head of physical medicine and rehabilitation center in King Abdulaziz Medical City in National Guard, Riyadh. We do have Dr. Mohammed Hassan al-Harbi, Director of Rehabilitation Center in King Abdulaziz Medical City also. And we have the third speaker, Dr. Abdul Karim Sulaiman Al-Hmayed, who is a chief physical therapist at Prince Sultan Military Medical City. And also we have Dr. Noura Al-Huaymil, who is associate professor and the vice dean of nursing college at Prince Sultan bin Abdulaziz and Kharj. So I welcome everybody to come here in the stage, and we start our session. And inshallah, bi'idhnillah ta'ala, we hope everybody will enjoy this session. So inshallah, we will start with Dr. Mohammed Nasser al-Shahrani in the title of his paper الابتكارات الرقمية في متابعة تحسين الأداء الوظيفي. تفضل دكتور محمد.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا لجامعة المجمعة على الاستضافة، وشكرا جزيلا للجنة المنظمة على الدعوة للمشاركة في هذا المؤتمر. Today we will talk inshallah about digital innovation in monitoring and enhancing functional performance post-stroke. First of all, I will be honest with you. I am not excellent in technology. And talking about something new in the field, we are usually not familiar with it. It will be challenging. But I started my presentation with the title, you know, it's necessity is mother of invention. So why people start to think about digital innovation in rehabilitation? So the most challenging, so this is are usually the challenging in current traditional practice in rehabilitation, which is limited therapy intensity, inconsistent dosing due to most of the time patient compliance, subjective progress tracking or monitoring the improvement with the patient, and resolving the limitation. So what are the solutions that came up with technology to sort out these issues? It starts with enhancing neuroplasticity, data collection, and increasing therapy access to those who has limitation to access therapy, and personalized intervention. So what's the aspect for rehabilitation, the innovation in rehabilitation aspect? Usually there will be more than one actually. The main one, which is the dominant one, is the motor functional rehabilitation. There are a lot of invention on that side, and the other side, actually not to miss, is the cognitive and language rehabilitation. Currently with the multiple apps and intervention for language training, evaluation of the speech recognition, semantic understanding, and also for the cognitive augmentation and enhancing the cognitive recovery with some invention. For psychological and social, this is actually one of the main barriers for people for community reintegration, associated with an anxiety, fear from the fact that he has disability and able to come. The virtual rehabilitation or virtual reality play a significant role in addressing this part. So most of my topic today is gonna be about motor recovery. So we'll talk about motor recovery, the current innovation available, which is including robotics, virtual reality, tele-rehabilitation, wearable devices, and neurostimulation. These are the aspects of digital innovation and rehabilitation part. So as you see in this picture, if we invest in all digital innovation with any stroke patient, might you see this picture from the head to toe, starting from virtual reality, augmented reality, gaming also, then inertial sensor, which is actually very important in tracking patient movement, speed, gait, including IMU, accelerometer, and other, actually other applications in smartphones or other uses. Wearable devices or assistive devices, including robotic exoskeleton, EMG, in advancing monitoring patient performance. Even in the foot, there are multiple devices could assist patient, like for sensor, smart insoles, and the other to track movement and mobility. So starting with robotic and exoskeleton, actually it's an assist to repetitive high intensity movement training. I would like to comment about one thing. As we hear usually, maybe in 20 years, some jobs will be disappeared from the fact. So I want to reassure all rehab specialties that it will be impossible for them to be replaced. So a technology or digital technology, in this case, it's an assist rather than replacement. We will come to it one by one. So for the robotic, there are robotic for upper limb training or tracking the improvement, tracking the movement and analyze it. And there is for lower limb, mainly for gait, exoskeletal, and robotic assessment. It's provide precise motion guidance, adjustable resistance, and detailed performance metrics. This is really very important in gathering the information for the improvement, for tracking progress with rehab, or for tracking planning for the future. So for the upper extremity, there are many options for assessment. It's clear in this picture. As you see, there are different robotic modalities that used for measurement and assessing hand function, analyzing the strength, analyzing the movement, and needed exercises needed, like mindfulness, motion, remo devices, and for lower limb, locomat, exo body weight support. It's mainly for gait, pattern normalization, and assessment. By the way, the evidence base in this part is actually shows from all articles there are moderate improvement in motor function, most effectively when it's combined with conventional therapy. So alone, there is no clear evidence on it, but there is moderate improvement with conventional therapy. So these are the different kind of robotic assistant. This also, as you see here, the most article has been done and assist. It's morely for walking independence that shows improvement with robotic digital. So, and this is another actually digital technologies that came up with the brain computer interfaces. It's actually the idea started from the blind people when they use the cane for walk. It started with sensors and they reapply it here for the functional assessment and detection. It's mainly used for severe disability to track to improve the neuroplasticity with applied electrodes that goes to express the signal from the head for the purpose movement to do it in the real training to enhance the neuroplasticity in a severe disability. The third digital innovation is the virtual reality or augmented reality, and it's actually to immersive the environment, simulate real world task, improving with evidence of improving upper limb function, balance, gait, and cognitive management / psychological as well. So it's from the VR training, it's increased the motivation, allow precise tracking for the movement quality. For the mechanism of action like this are virtual reality rehabilitation. It works mainly to immersive task practice, real-time feedback, gamification of increasing engagement, graduate difficulty progression, and it's applied more, as you see, in multiple aspects in balance, postural, control, upper limb extremity coordination, and cognition motor integration. As you see in the last one is about the spatial neglect. It starts to assess spatial neglect, enhance patient to interactive with the surrounding by simulation. This from the evidence-based, this is actually RTC was done, and it shows about 20% improvement in limb function versus conventional therapy. As you know, it's very difficult to assess it because this has been done usually in a special situation due to a lot of barrier to implement it in the community. So it was done in a research purpose. It's not actually real treatment. So the strongest effect was for upper limb functional ADL performance, and the limitation in the virtual reality, it comes usually with the motion sickness. Those patients with severe vertigo and technology cost, supervision needed. So still with that, it still needs supervision assessment. So then telerehab is usually video-based evaluation protocol with guided exercise. It's better to be assessed and evaluate when patient using wearable sensor integration to gather all exercise and monitoring for post-exercise performance. Tele-rehabilitation, its benefit including a greater accessibility for those who has limited sources for rehabilitation, reduce travel burden, and improve engagement of the patient. Challenging actually still remain. The cost is the main barrier for implementation for any digital innovation in rehabilitation, implementation, and clinical integration with the patient for assessment. So then wearable devices. Wearable devices, there are two kind of wearable devices, like for smart devices like accelerometer and AMU. IMU is stand for inertial measurement unit. It's very precise tools to assess the speed, movement, reaction of the patient movement, and it helps for tracking movement quantity, quality, and symmetry as well. Accelerometer actually it's a part of IMU, but it's mainly specified for the speed, and it monitor gait pattern, arm use, heart rate, and activity level. Also, the other option is EMG, which is recording the muscle movement, and depends on that grading the improvement with rehab, monitoring the neuro recovery with biofeedback of motor learning. Then Internet of Medical Things. It's actually started with the major disease behind the rehab, like tracking blood sugar, tracking blood pressure for the patient. Then it started to integrate the sensor in the monitoring, including the dashboard, personalized therapy adjustment. This system actually remote assessment, early detection of decline, adapted rehabilitation plan. So there are actually limitations for these things. We will talk about it inshallah at the end. Home-based digital rehabilitation, which is designed actually for independent use, including motion tracking camera, as you see in the previous picture, tablet-based exercise program, smart objects for hand therapy. The evidence-based here shows actually home-based digital tools can be effectively support upper limb rehabilitation, especially when combined the therapy of sites. So, and the fourth part is the neurostimulation. We will not gonna talk about it in details because there will be a lecture about it, including transcranial magnetic stimulation, transcranial direct current stimulation, and functional electrical stimulation. These are the picture of neuromodulation. So for the innovation, how this innovation improve functional performance, it's actually in two parts, in monitoring and enhancing. The monitoring, it continuous tracking of the movement, activity, physiological signal, also early detection of complication or functional decline, objective data for clinician to adjust the therapy. Then enhancement with the high repetition, task-specific training, personalized feedback, and adaptive difficulty, increased motivation through gamification, greater therapy intensity outside the clinic. So these are the enhancement of digital innovation. So integration to the clinical practice. This is how can we integrate it? It's actually by starting by patient selection, would assess patient cognitive status, motivation, and technology. Then to put goal alignment, which is goal setting, matching the technology to functional objective that's needed from the clinician. Then hyper protocol, combine tech with conventional therapy. This how can we implement it? Then dose optimization depends on the outcome. It will drive the outcome, the data that we collect. Outcome tracking, you use standard measures to tech-generated data. This is, I think, there's very important things about what's the barrier currently to implement this innovation in a clinical practice. It's the cost first, the cost. So most of center cannot afford such high investment in this one or limited reimbursement model. Training, it still need clinician training and technical support to track and collect all the data. Then infrastructure, the speech requirement, IT integration, challenging. Then the last one, which is about the evidence gap. So till now, no clear outcome since it's not applied for the clinical practice, or and there is no clear protocol when it will start and when it will be used. One more thing, which is actually ethical part, which is really dangerous in this situation, about the data of the patient and accessibility to it, patient privacy. So it's still no solid protocol in this part. So emerging the future, maybe brain computer interface. There are a lot of things: AI-driven personalization, biomarker integration, smart home ecosystem. These are the future. So take-home message, evidence support technology as assistant, adjustment, but not replacement. So greatest benefit when it's combined to the skill therapy, intensity and dose matter more than modalities. So as we know, the intensity of rehab is very important for anyone. Patient engagement drive the outcome. So patient must be motivated to participate, otherwise it will not be easy. Implementation require strategic planning. So it will need clear protocol, strategic planning to implement this digital innovation in the clinical practice for all the patients. This is my reference, and thank you for listening.
Thank you, Dr. Mohammed, for this informative presentations regarding digital innovation, monitoring, and enhancing functional performance. We are welcoming the second speaker, Dr. Mohammed Hassan Al-Harbi, who is the Director of Rehabilitation Services in King Abdulaziz Medical City, Riyadh, with his title Machine Learning and AI in Stroke Rehabilitation.
First, I would like to thank Majma University and the Scientific Committee for inviting me again. And I would like to apologize first because I'm a little under the weather, so please forgive me for any gaps in my voice or my memory. My lecture is an extension to Dr. Mohammed lecture, so we will try to skip some of the shared slides. Also, my aim is to convince you to utilize intelligent system, then to convince you not to utilize intelligent system. Then we will have a discussion about what the limitation about and why we should and we shouldn't use the intelligent system in our clinic. So, Bismillah ar-Rahman ar-Rahim. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. So, as a general rule of thumb, stroke rehabilitation is built on repetitive, intensive, task-oriented, challenging our patient in our rehabilitation setting. So, when we say repetitive, intensive, challenging, and novel task, all these factors are taken in consideration when we utilize exoskeletal or robotic-assisted therapy. However, an evidence-aligned clinical work is never the same. We always have shortage of staff. We always have utilization of the machine. We always have rural area who don't have all the machine, and we always have a difficult or not cooperative patients. So mixing a high-tech clinic with low staff is not an ideal or an encouraging environment. So with the digital health and AI approaches are increasingly framed as a capacity multiplier. It's not a replacement for the physical therapist, occupational therapist, and speech pathologist. As Dr. Mohammed mentioned before that, will AI and robotic system replace therapists? I think yes and no, but let's discover why, and then we will have a discussion about it. So when we talk about intelligent system, we are not talking about one machine. It should be an ecosystem that take in consideration upper, lower, cognitive, visual, perceptual, all these kind of factors that help the patient go from disabled to unable person. However, when we adapt the recommendation or the therapy, still we need some coaching. We still need some safety consideration, some operational manual, safety manual data sheet, rules and regulation on how to use the machines. And then one of the important thing is you can have all the machines or AI in your clinic. However, the design of the rehabilitation program and how you embed these machines into your clinical work is very crucial and very important part. The five factors where the AI and the intelligent system work is digital measurement and remote monitoring, personalized rehabilitation planning, virtual reality and home-based therapy, robotic-assisted rehabilitation, cognitive and communication rehabilitation. The AI and intelligent system, they put what we call a biomarkers. They give you data, and it falls on you as a therapist on how to utilize, how to interpret, and how to implement these data into your clinic. So, in the measurement and revolution, traditionally what we do in our clinic is we do assessment and reassessment. So we do a periodic assessment scales with a human factor that it's limited to sensitivity, and it's a clinical-based snapshot. It gives us a snapshot about the patient condition at this time, at this situation. When we have the intelligent system, they are continuously monitoring the patient. They give us real-time data about the patient condition, and they give us if there is any correction needed to apply in the system. Also, it have a symmetry synchronization, and it can be utilized in home monitoring. One thing is, we notice as a clinician that a stroke patient is never a stroke patient. We never have a stroke patient that came us with just a stroke. They always have something else. They always have dyslipidemia, DM, they have depression, psychosocial issues, they have a lot of things that the machine does not look at it from this point. They look at a task and they want to do this task. But the human interaction will look at the patient in a different way. They will look at the patient as a human, as a performer, as a contributor to the system, to the environment, to the economics, and that's one of the differences that the machine versus the human use. Visual rehabilitation and home-based therapy is very interesting topic, because there is a virtual reality and there is augmented reality, and how we can utilize it in our patient's home. In the meantime, it's very easy to have a VR or augmented reality in our clinic. However, when we transfer this to the patient's home, it looks at about the safety issues, about the installment and the calibration of this machine, and how the patient will be able to utilize and use this machine in their home. However, the evidence showed an improvement function, especially in the upper limb function, and with strong potential for outpatient scalability. Robotic and intelligent control. One of the best and highly features of using robotic assisted therapy is they give you maximum repetition, same factors, same kinematic factors, and that's sometimes it's very difficult on the clinician to repeat the same task the same parameters, the same period of time for the patient. So one of the aspects that robotic-assisted therapy has a factor up on human is their ability to repeat and repeat and continuously challenge the patient without feeling fatigue or feeling discrepancy in the performance. And when we use AI, I think one of the questions was presented in the previous session is, are we using AI in our clinic? I think we should use AI and machine learning in matter of stratification and prediction, not as a treatment or help in a treatment, because they can give us the data, the comparison data with the environment, with the expectation. However, it falls under the therapist's responsibility to know how to use his skills, his or her skills in the clinic, and how to improve the patient function. So the AI and robotic assisted should be as an assistance to you, not as a replacement to you. Okay. In matter of cognitive therapy, I know that Dr. Muhammad already spoke about cognitive therapy and the implementation. And I want to mention that one of our colleagues, she's a speech pathologist therapist in Riyadh. She took on her part that to develop an application that help the patient in Arabic, in our culture, in our environment. She developed an app. I will be happy to share the information. So I will be happy to share the information later on. But she adapted the AI and the telehealth for cognitive and speech pathology. And this is one of the aspects that the data shows that there is a huge improvement with the AI and the platforms in terms of speech and cognition patients. Okay. So now the question is, will AI, robotic assisted therapy, replace the human therapist? I will leave this to you to answer it, but I think I will prefer a rehabilitation center with human therapist rather than a lot of machine and two therapists, because we cannot exclude the human factor, we cannot exclude the interpretation. And one other thing is, as a therapist, we look at the patient as a holistic person. We look at shoulder pain and how the shoulder pain has an impact on gait, and how it has an impact on sleep, how it has an impact on the patient's personality, mood. Did the patient eat today? That's maybe why his performance today is down, because he did not sleep yesterday. In TBI patient, we prefer the patient to sleep a lot rather than being a lot of activity in the gym. So the human factor remain an essential factor in the rehabilitation process. And don't take my word for it. We will look just to the evidence about how we will look at comparison evidence between utilizing AI and robotic assisted therapy in the clinic. This is a 2024 study. It looked at the functional and motoric outcome of AI-assisted rehabilitation. It's a meta-analysis of a randomized controlled trial. AI-assisted stroke rehabilitation was not inferior to conventional therapy for functional outcomes using Barthel index and motility index. Standard mean difference indicates small to moderate improvement, but not statistically superior. The analysis conclude non-inferiority suggestion technological approach are at least as effective as traditional method. This one, I think it's 2017 or 2024. It looks at the benefits of robot-assisted upper limb rehabilitation from subacute stage after a stroke of variety of severity. It's a multi-center randomized controlled trial. Several RCT shows favorable or comparable effect of robotic-assisted therapy on upper limb motor function versus traditional physical therapy. However, some study reported improved engagement and comfort though not all showed significant functional superiority. The evidence highlight variability based on patient subgroup, robot type, and therapy intensity. This is the 2017 study. It's a comparative study of conventional physiotherapy versus robotic assistive gait training associated in physical therapy individual with ataxia after stroke. Both robotic and therapist-led gait training produced significant improvement in balance and functional measures. Some studies found no significant differences between robotic versus conventional gait outcome. So there is a conflicting result exists. Some smaller trials suggest robotic may improve gait measure, while others show similar outcomes to therapy training. This is, I think, 2025 study, an AI-driven cognitive telerehabilitation for stroke. It's a randomized control trial. Both groups showed significant improvement in cognitive tests. Non-inferiority was demonstrated. The AI system was not inferior to therapist-supervised therapy or primary outcome. High usability and no serious adverse event were reported. And this is a comparison between the 5 studies that I presented. It's non-inferior, similar effect, non-inferior, and comparable or favorable gains. There's also the ethical and consideration that talk about the patient HIPAA, the patient rights and privacy, the patient information not to be sold. And we know that any data that is entered through a system at some time, it will be available to marketing and companies to manufacture based on these data. An implementation framework for hospitals, it's recommended strategy that they should define and narrow as much as possible their clinical use. It is better for them to utilize what they need rather than just buy whatever it's presented to them. They should establish safety escalation protocol integrated into the electronic medical record workflow, train staff, monitor outcomes continuously. Future research priorities, we must improve a large multi-center trial, explainable AI models, participation-based outcome metrics, and I want to talk about this. In our institute, we have, I think, at least 3 robotic-assisted therapy. We have 2 to 3 VR machine, and we have bodyweight-supported treadmill. Alhamdulillah, we are very blessed and fortunate in our centers. However, all these machines, when they give us our result, they show it by spatiometric factors. They tell us the speed, the gait speed, the cadence, the spatiometrics, but they don't tell us the Barthel index. They don't tell us the dynamic gait index. They don't give us the Berg balance scale, what we use in our clinic. So there is a discrepancy between the result that they are produced and the result that we want to use in our hospital. Take-home message is, intelligent system will reshape stroke rehab delivery. AI enhance, not replace human. They are reinforcement, not a replacement. And success depends on governance, safety, and integration. Patient-centered, participation-focused design is essential. Thank you very much. These are my references. Thank you for your attention.
Thank you very much, Dr. Muhammad, for this interesting topic regarding AI in stroke rehabilitations. So we welcome the third speaker, Dr. Abdul Karim Suleiman Al-Humayid, who is a chief physical therapist in Prince Sultan Military Medical City, with the topic role of neuromodulation supporting recovery.
السلام عليكم ورحمة الله وبركاته. كالعادة كل سبيكر يوقف يقول شكرا ثم شكرا ثم شكرا. صراحة يعني جدا سعيد بتواجدي معكم، واشكر كل اللجنة المنظمة، واشكر كل القائمة على أن خرج مثل هذا الإنتاج العظيم. عبد الكريم سليمان الحميد. أنا فيزيكال ثيرابيست من 31 سنة والله الحمد والمنة. يعني أنا تخرجت من جامعة الملك سعود 1994. ممكن بعضكم ما انولد. زين. طبعا شكرا لزميلي صالح بعريجة، جاي من الرياض وتكبد، الله يعطيك الصحة والعافية، يجعل في ميزان حسناتكم. أنا لما أجي أتكلم عن الفيزيكال ثيرابي، الرسالة الأولى، كم واحد فيزيكال ثيرابيست ايذر ستودنت ولا ستاف ولا موجود في هذه الغرفة؟ الفيزيكال ثيرابيست يرفع ايده، اوكيبيشنال ثيرابيست يرفع ايده. لا تخافون، انتم التارجت حقتي، يعني حسألكم واللي ما يجاوب سيعاقب. زين. بعيدا عن طرح المحاضرة بين محاضر ومتلقي، خلونا يعني نكون شوية فليكسبل. أول شيء، أول رسالة أنا أبغاكم تعرفونها، أنا أقول لكم إياها خبرة 31 سنة، والله الحمد والمنة، والله يجعلها يا رب العالمين نافعة للبلاد والعباد. لازم تعرفون لما أنت as a physical therapist, when they mention that the stroke patient or stroke disease is a second mortality, morbidity, it means that the load on physical therapy precisely, it's very high. يعني لما يجي يقول لك إنه في العالم يحدث في كل ثانية one stroke, that's mean أنت كphysical therapist you have to be proud that you are on need. هذه الرسالة الأولى اللي إحنا كلنا as medical practitioner and precisely as a physical therapist. أنا لما أجي أقول we are a physical therapist, that's mean no full rehabilitation, no full medical care without a rehabilitation. That's mean يعني حط ثقل على ظهرك، لكنه هذا قاعد يعطيك أهمية قصوى في عضو بأن تكون عضو من أعضاء الريهابيليتيشن تيم. فإذا أنا كفيزيكال ثيرابيست لما أجي أتعامل مع الستروك بيشنت ما أتعامل لها مع أي إنسان عادي، أو ما أتعامل معها أي ميديكال براكتيشنر ثاني. هذه النقطة الثانية. النقطة الثالثة أو الرسالة الثالثة قالها الدكتور محمد الشهراني وقالها الدكتور محمد حسن الحربي، ال AI هدفه مساعدتك أنت في البروفيشنال حقتك، ليس الهدف replacing you. هذه نقطة جدا مهمة. ما ممكن أي انترفنشن يحصل على ستروك بيشنت حسب علمي وما ذكر من قبل إلا ويتكلم عن إنه it will assess you, it will not take, it will not replace you. يعني معناته إنه ما راح يأخذ مكانك. يعني لا تخافون. من 30 سنة بكل شفافية كان مصطلح الستروك مصطلح جدا غريب. يعني كنا في واحد من قبل 31 سنة يا جماعة الخير لما نسمع patient جاته ستروك في المستشفى العسكري بالذات، كان عدد أسرة الستروك، عدد الأسرة في 94 95 عدد أسرة الستروك 2. والآن إحنا في المستشفى العسكري 18 سرير، وهذا length of stay does not go beyond 5 days. يعني فترة بقاء المريض في المستشفى العسكري في وحدة السكتة الدماغية لا يتعدى 5 أيام. معناته أنه اللونج رانينج قاعد يشتغل. أنا كفيزيكال ثيرابيست قاعد يحط علي اللود جدا عالي. هذه المسج اللي أنا حابب أعطيكم إياها قبل لا نبدأ محاضرتنا. Functional electrical stimulation. معنى لما أنا أجي أستخدم الفانكشنال electrical stimulation معناته أنا قاعد أستخدم حاجة electrical stimulation الهدف منها أنها تعطي وظيفة للمريض، يعني يقوم بأداء وظيفة، يعني function. It is not a matter of a static movement. كلنا كفيزيكال ثيرابيست نعرف ايش معنى static movement. It is a dynamic movement. احنا الهدف من الفيزيكال ثيرابي او FES اسف functional electrical stimulation انه تعطي حركة، يقوم المريض بأداء حركة وظيفية تساعده على نقطة جدا مهمة الاندبندنسيز. كل المحاضرين اللي سبقوني كانت النقطة الأساسية activity daily living 1 2 independencies. جدا مهمة انه انا اسعى لتحقيقها. فاذا الجول اللي انا اسعى من الفانكشنال الكتريكال ستيميليشن independencies، وهذه نقطة جدا مهمة. انا كفيزيكال ثيرابيست عمتنا بوباث، عمت النيورو ريهابيليتيشن، من يوم 1907 كانت المشكلة الأساسية اللي واجهتها بوباث وكل الفريق الطبي من ذاك الزمان إلى الآن قضية الموتور كنترول موفمنت اللي موجودة مع المريض كانت هي من أصعب المشاكل اللي قاعد تواجه المريض في قضية الاكتيفيتي ديلي ليفينج والاندبندنسيز اللي احنا تكلمنا عنها واللي نسعى لتحقيقها as medical practitioner. فإذا المشكلة الأساسية اللي احنا قاعد تواجهنا اللي هي motor control of movement، اللي هي motor dysfunction. هذه النقطة الثانية functional limitation, sensory and perceptual issue. فإذا أنا as a physical therapist my goal with my patient independencies functional task. كل الميديكال practitioner starting from the team leader as a doctor to a physical therapist, one of the team leader, when they refer the patients to them, they are aiming for one important thing, taking the patients out of the bed. المحادثات الجانبية نوقفها لو سمحتوا. ألو أي أنت اللي دس المحادثات الجانبية نحولها بعدين. الهدف من الريفيرينج بيشنت إلى الميديكال براكتيشنر، الهدف من التحويل البيشنت للميديكال براكتيشنر إخراجه من السرير. زي ما ذكر أمس الدكتور it's very costly financial issue, it is very costly. Therefore لما أنا كphysical therapist referring patients to me, I want to take the patients out of the bed as soon as possible because financial issue it costs a lot. But وهذا اللي ندخل فيه من مدخل محاضرتنا. أنا واحدة من المشاكل اللي تواجهني لما يجيني patient مع stroke, weakness, motor control, functional disability, sensory impairment. قاعد أواجه مشكلة في قضية الدورسيفلكشن اللي موجودة في الافكتد سايد، الموجودة في الافكتد سايد في الرجل المريض. فإذا أنا لما أجي أشتغل مع الستروك بيشنت أركز على قضية شيء إحنا نسميها دروب فيت. ليه أركز على الدروب فيت؟ وإيش عنوان المحاضرة فانكشنال الكتريكال ستيميوليشن؟ وجدوا إنه الدروب فيت ويكنس في الدورسيفلكشن أو الدورسيفلكسرز weakness في الدورسيفلكسرز واحدة of the main causes might lead the patient to fall down. هذه المشكلة الأساسية، الطيحة. أنت لما يطيح معك مريض stroke geriatric, that means risk of fall is high, risk of other deficit or injury might happen. Fracture neck of femur minimally, that the patient post-stroke had a fall. أنا أخاف من حاجة fracture neck of femur. Fracture neck of femur that means further complication. فإذا المشكلة الأساسية اللي تواجهني أنا مع الستروك patients drop feet. فلذلك ندخل من هذا المدخل. وجدوا أو اكتشفوا شيء يسمونه functional electrical stimulation. فإذا ال FES to prevent weakness in dorsiflexors might lead to risk of fall. So goal of physical therapy with a functional electrical stimulation to prevent fall. واضح كلامي؟ خلونا نتكلم بالعربي خنفشاري. الهدف من ال FES انه نعطي المريض تقوية للعضلة التيبيالس انتيريور علشان تساعد المريض في انه يمشي بامان حتى ما يطيح. واضح؟ فانيشيالي في البدايات للحل المشكلة هذه اكتشفت اللي احنا نسميها AFO الانكل فوت اورثوسيس، اللي نسميها كلينيكالي ستاتيك انكل فوت اورثوسيس، دايناميك انكل فوت اورثوسيس، دايناميك انكل فوت اورثوسيس. اخترعت ال AFO واستعملت مع المريض وبدأ المريض يمشي بكل سلاسة prevent الفول prevent أي dorsiflexion أو dorsiflexors weakness. بذلك بدأ البيشنت يصل إلى مرحلة أساسية احنا ركزناها في أول سلايد independencies safety independencies. واضح الكلام؟ ننتقل للخطوة الثانية. الآن احنا مع ال AFO we were in peace. احنا مع ال AFO كنا في peace. البيشنت بدأ يوقف ويمشي ويتحرك. Risk of fall minimized. Risk of dangerous safety is optimum. ممتازة. Therefore الآن طلع a new invention حاجة جديدة اللي احنا ندخل الان من المدخل للمحاضره حقتنا، انكل فوت اورثوسيس باستخدام شيء نسميه فانكشنال الكتريكال ستيميوليشن، اختصره FES. واضح الكلام؟ فاذا FES هو replacing AFO، replacing AFO لمساعده المريض انه يتحرك independencies ويطلع ويروح ويرد بدون اي مشاكل تذكر في حياته اليوميه. ما نبي نتكلم عن التفاصيل، لكنه الجميل فيها المسج الاساسي take home message، الرساله اللي انا ابغاكم تاخذونها معكم الى البيت as a physical therapist precisely، انه بدا في عام 1990، هذه من اول البدايات، وكانت النقطة الأساسية واللي استعملت فيه كانت مع نيورو بيشنت مع دروب فيت. فإذا هذا التارجت اللي هذا الهدف اللي احنا قاعدين نسعى له، دروب فيت with a stroke patient. ليش دروب فيت؟ محادثات جانبية ممنوعة يا شباب. دروب فيت، شكرا يا ذكي تعجبني. فإذا الدروب فيت مشكلة أساسية قاعدين يشتغلون عليها to prevent risk of fall. زي ما قال الدكتور محمد الشهراني، a lot of sensors with the machine applied to the patient starting from the top زين till the toe. يعني أكرمكم الله electrical stimulation والphysical therapist يصحى لأنه أبي أسأله سؤال مهم. Electrical stimulation applied on the patient for the affected side AFO with the sensor in the shoes. With the sensor in the shoes to help the patient to initiate dorsiflexion to prevent ايش؟ risk of fall. فإذا الآن شالوا الAFO dynamic البلاستيك وحطونا electrical stimulation. الهدف من الAFO prevent fall. الهدف من الfunctional electrical stimulation to prevent fall. فإذا الآن هم يجتمعون في حاجة واحدة أساسية. سؤال BTs، الBTs اللي تو رفعوا يدينهم يرفعون يدينهم. صالح ممنوع السؤال. What type of electrical stimulation, what type of electrical current applied in this machine؟ ناخذ الإجابة في نهاية المحاضرة. طيب فإذا الهدف من FES to prevent a fall. ناس الشغالين OT they use it for the upper limb as well. They used FES functional electrical stimulation. بدأ التاسك حقها يكبر شوي. بدأ اللور لمب التارجت حقت الفيزيكال ثيرابيست بدأ الآن يشتغل حاجة ثانية اللي هي upper limb for functional. مثل ما قال الدكتور محمد بدأت الالكتريكال ستيميوليشن يستعملونه مع الupper limb function. وطبعا upper limb function الناس اللي حيشتغلون مستقبل مع الستروك patient one of the most common complicated parts post-stroke. عادة ال upper limb normally it gets recovered very late because of a lot of things. زين فإذا الآن بدأوا يستخدمون functional stimulation مع ال upper limb. الهدف منه هذه نقطة جدا مهمة. المسج الثاني اللي أنا أبغاكم second home message to take it home. الحاجة الثانية لما استخدموا dynamic AFO ما كان فيها voluntary movement، ما كان فيها active movement، ما كان فيها strengthening exercises، ما كان فيها أي treatment للمصل اللي أنا قاعد أستخدم مع ال AFO. كانت static ولا فيها أي contraction. isolated للجوينت تماما، ثبتوا الجوينت وصار في isolation للجوينت تماما حتى المصل. لكن لما استخدموا ال FES functional electrical stimulation تحولت. أنا ضربت عصفورين بحجر واحد، مشى البيشنت كويس بدون أي risk of fall، واستخدموا كمان improve muscle strength. هذه النقطة المهمة اللي أنا gaining from the FES. فإذا الآن انتقل من static no contraction انتقل إلى إنه electrical stimulation functional electrical stimulation used to strengthen the muscle. فإذا أنا improving. كثير مننا اللي يشتغل clinically مع البيشنت you will ask patient will ask you either with the upper limb or with the lower limb how long do I need to apply the splint? How long do you recommend me to use the splint? Do I need to apply it whole day or not? أنا متأكد كل واحد يشتغل مع البيشنت. Patient, you will ask or you will answer this question asking the patient, no, listen, I don't want you to apply this splint rest of the day. Take it off when you want to do some rest and do exercises. We do believe in this room, I'm sure 100%, we do believe, although this splint is beneficial, like unfortunately, it has a side effect as a static, as AFO normal. It might lead to atrophy, muscle weakness, unfortunately. But with the functional electrical stimulation, الحاجة تغيرت. They aim for improving the muscle power, which we like it. Message الثانية, physical therapist. Physical therapist هذه المسج اللي أنا أبغى الجميع يجب أن يكون فيه على علم. Is it all patients applicable to apply functional electrical stimulation, FES? هل كل مريض أنا أقدر أطبق عليه الفانكشنال إلكتريكال ستيميليشن؟ واحدة من أهم المسجز اللي أنا أتمنى من الجميع في هذه الغرفة سبيشال فيزيكال ثيرابيست، نحن نعرف حاجة تايب أوف نيرف إنجري. عندنا إحنا 3 تايب أوف نيرف إنجري: نيوروتوميسيس، نيوروبراكسيا، أكسونوتوميسيس، نيوروتوميسيس مثل موجود بالسلايد. نوع الإنجري هي اللي تساعدني أنا كفيزيكال ثيرابيست whether this patient is a good candidate for FES or not. نعرف إيش معنى نيوروبراكسيا. نيوروبراكسيا that means the nerve itself تغطى. أي نيرف يغطى بإيش يا شباب؟ أي نيرف يغطى بإيش؟ أي نيرف بالجسم إيه مايلين شيت. زين، يغطى بمايلين شيت. شكرا على الإجابة دكتور عبد العزيز، لو سمحت إذا كان هذا نيورو تنجح الأول. زين، شكرا على مشاركتك. فإذا any nerve covered by myelin sheet. What is the function of myelin sheet? Helping conductivity of the nerve. Impulses. الهدف من المايلين شيت يساعد في الكوندكتيفيتي. يعني ايش معنى؟ دكتور ممنوع المحادثات الجانبية. ممنوع المحادثات الجانبية لو سمحت، مثلك مثل غيرك. فإذا aim of myelin sheet conductivity. Neuropraxia يصير فيها injury للمايلين sheet. Normally myelin sheets get recovered very quick within a week. صح صالح؟ Within a week's patient myelin sheet will be recovered. فإذا this type of patient is a good candidate for functional electrical stimulation. Okay? 2 نيورو اكسونوتوميسيس. اكسونوتوميسيس الانجري نزلت شوي بالمايلين شيت وبدت تنزل تحت، صار الانجري من المايلين شيت الى الاكسون. there is an injury. ما that mean الامبلسز بدت تقل، كوندكتيفيتي بدت تقل، معناتها المصل في النهايه ما قاعد تشتغل كويس. therefore this type of patient is a good candidate. يعني لك عليه. لكن لما يصير عندك النيوروتوميسيس لا، this patient is not good candidate for FES. ليش؟ رسالة اللي أنا أبغى سألتكم إياها as a physical therapist من قبل. اللي يجاوب حيتخرج من الآن حتى لو كان بالسنة الأولى. دكتور عبد العزيز رايك في ديسكاونت؟ فإذا the type of injury is very important. The type of current you apply with the patient is very very important. زي ما قلنا هذا الادفانتج. ذلك جدا مهمة نحن نعرف ايش مين مع كل مريض. لا، ما كل مريض احنا نقدر نستخدم. هذه المشكلة الأساسية. فإذا معرفة البيشنت والانجريز اللي موجودة بالنير هي جدا مهمة. Can I apply FES or not؟ هذه نقطة كمان جدا مهمة. كذا علشان ما تملون. The secret of change is to focus all your energy not on fighting the old, but on building a new habits or new things. احنا نستخدمه functional electrical stimulation كما ذكر الدكتور محمد. Functional electrical stimulation أيا كان، سواء البارتس or all over the body, could be used for spinal cord injury patient, could be used with the traumatic brain injury as well as with a stroke patient. The aim ايش الهدف منه؟ stand up and walk. stand up and walk. اللي ينتقل بعد الانترن واللي لسه ستودنت ولا واحدة من أهم الأهداف اللي يتعلق فيها البيشنت بالفيزيكال ثيرابيست واللي يعشق البيشنت الفيزيكال ثيرابيست من خلالها بليز I want to stand up and want to go to the bathroom. هذه الرسالة أنا سمعتها من يوم إني 95 وإلى اليوم 2025 أو 26 أنا ما زلت أسمع هذه الرسالة. دائما البيشنت his goal I want to go stand up and go to the bathroom. هذه كمسلمين هذه اللي إحنا we are aiming for. كل مريض يجي عندك يعرف إنه أنت الشخص اللي المسعف والمنقذ، يقول لك بليز طلعني من السرير، أنا مليت من السرير، لا تزعلوا مني، مليت من الحفاظة، مليت من إنه أحد يجي يشيل الوسخ من خلالي. I want to stand up, I want to go be independent. هذه النقطة الأساسية كل مريض مسلم موجود في المملكة العربية السعودية. مكونات ال FES. مكونات ال FES هي عبارة عن electronic stimulator موجود everywhere، بس مع الفانكشنال electrical stimulation موجود في التيبياليس anterior، موجود في الشوز as a sensor to help the patient to stand up. ايش الفسيولوجيكال؟ المسج الأخيرة. please 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 and please. دائما لما تتعامل مع أي patient أو مع أي instrument, whenever you use instrument, you have to go and dig deeply about the physiological components. أنا أعرف كل اللي في الغرفة كانوا يكرهون مادة الفسيولوجي، والدكتور اللي كان يدرس الفسيولوجي دكتور مكروه، ما حد يحبه إلا ما ندر، قليلين جدا. الفسيولوجي يتبسم الدكتور، شكلك أنت دكتور فسيولوجي، صح؟ صح وفسيولوجي؟ أي، فمادة الفسيولوجي من أمتع المواد عندي أنا شخصيا، مادة جدا ممتعة. دائما 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 احنا نسأل نفسنا ليه يستخدمون الفانكشنال الكتريكال ستيميليشن؟ ليه استخدموا الفانكشنال الكتريكال ستيميليشن؟ فانكشنال الكتريكال ستيميليشن يعني الكلام العلمي انهانس النيوروبلاستيسيتي، انهانس الموفمنت. انا النقطة الأساسية لهذه انا ارسلها، اللي انا ابغى المسج ان تصل الى الجميع وياخذها للجميع. أي electrical stimulation applied to the patient should work on a motor components, a motor function, a motor structure. هذه ال a motor structure هي اللي يطبق من واللي يستعمل من خلالها الفانكشنال electrical stimulation. أي impulses تجي للمصل، سامحوني ما عندي أي pointer، electrical stimulation يشتغل على المصل، يطلع للسباينال كورد، من السباينال كورد يروح للبرين، بعد ذلك تنزل الموفمنت. فإذا الفانكشنال الكتريكال ستيميليشن هو هذه الطريقة اللي يشتغل فيها الفانكشنال الكتريكال ستيميليشن. Sensation comes from the foot, then after that goes to the spinal cord, to the brain, then the movement comes to enhance the movement. زي ما قلنا controller, electrical stimulation, skeletal contraction, then action movement أو active movement. فإذا هذه المسج، هذه الإيفيدنس استعمل، ما في شك، استعمل الفانكشنال الكتريكال ستيميليشن to enhance إيش؟ during walking training using إيش الهدف؟ during walking to prevent any risk of fall. هشام قال إنه walking with the electrical stimulation reduce pain and improve mental health. Improve mental health. هذه نقطة جدا جميلة. Question. السؤال الأول. خلصنا. تقدرون الآن ترتاحون ولا تخافوا من الأسئلة، بس في سؤال الفيزيكال ثيرابيست لازم يجاوبه بعدين. What does functional electrical stimulation primary aims؟ ايش تتوقعون الإجابة؟ يلا بصوت واحد. ايش الهدف من الفانكشنال الكتريكال ستيميليشن؟ هل هي pain relief, muscle relaxation, functional movement restoration or skin healing؟ يلا بصوت بدون لا حد يستأذن. سي احد نصراوي؟ كلنا نصراويين صح؟ كلكم نصراويين. سؤال أخير. Which type of patient would be benefits from functional electrical stimulation؟ لا تقولوا لي سي مرة ثانية. أنتوا على وجهتوني كذا، أنا بطرح محاضرة الأسبوع الجاي معناته كله بحط سي علشان كله يقولوا النصراوية سي. طيب يلا الإجابة. Neurological impairment, patient with skin, patient with acute infection, patient with osteoporosis. ايه يعطيكم الصحة والعافية. شكرا. يلا physical therapist. What type of electrical stimulation we use? What type of current? What type of current? حتى أكون دقيق في سؤالي صح. What type of current we use and why? يلا صدقوني تنجحون الأوائل. بس يلا أنت مرة ثانية تخرج يا أخوي. خلاص غيرك. اللي جنبك بيتي. اي يلا. لا اللي جنبه مو الجنب اللي جنبه. لا مسكين كاب بردان. ناخذ 3 إجابات. لا مو بالكاب أنت اللي بالنص. اي أنت اللي صرفت. What type of current? ايوه أحد يعرف؟ أحد تعرف؟ البنات هم دوافير. What type of electrical current؟ احنا نستخدم مع ال FES. يلا. What type of غالبا احنا نستخدم اي اسمع صوت وراء اي اوبو تبارك الرحمن.
Action potential same with the
اي صح. شو اسم الكرنت؟ نيوروتوميسيس لا في نوع من انواع الكرنت احنا درسناه في الالكتروثيرابي يستخدم عاده في الاف اي اس. Faradic electrical stimulation normally used with the patient as a faradic current لانه مع الجلفانيك المصل دي انرفيتد لكنه مع الفراديك والاف اي اس نستخدم الفراديك electrical stimulation as because of the muscle is innervated. انا اسف اخذت وقت طويل من دكتوره الهويمل سامحيني اعتذر منك يعطيك الصحه والعافيه. شكرا.
Thank you, Dr. Abdul Karim, for this inspiration talk. We're going to go to our last but the least speaker, Dr. Noura Al-Huwaimil, who is Associate Professor in Sultan bin Abdulaziz University in Kharj. She will talk about trunk recovery post-stroke.
السلام عليكم. في البداية أنا حابة أشكر جامعة المجمعة، حابة أشكر اللجنة المنظمة على هذه الدعوة الكريمة، على حسن التنظيم، حسن التواصل وهذا البرنامج العلمي الثري. حابة أشكر أيضاً زميلاتي وزملائي ممن سبقوني على المادة العلمية المثرية اللي قدموها. Today I'm going to present my research in trunk recovery post-stroke and the use of technology in the assessment and rehabilitation of trunk post-stroke. Why trunk? Trunk ability is often overlooked as an integral part of the recovery process. The majority of the published literature and rehabilitation program focused on the upper limb and lower limb rehabilitation, although trunk plays an important role in holding body upright. And trunk recovery and trunk impairment has been well recognized. Trunk control has been well recognized and as an important early predictor of functional recovery post-stroke, as it could explain 71% of variance of functional recovery. And the recent work by Al-Umari and their colleagues in 2024 in exploring the role of trunk control in functional recovery post-stroke, they measured trunk control tests in acute stroke at admission in King Fahd Hospital, and they have found that trunk control test was the strongest predictor of normal living index and mobility, community mobility post-stroke. Another recent work in 2025 trying to answer a fundamental question about which brain lesion associated with trunk impairment early after stroke, and they measured trunk control test at admission, and all of the 156 participants underwent an MRI, and their analysis showed that poor trunk function associated with the lesion in the right corticospinal tract, and this relationship remains significant even with the analysis adjusted and controlled for the limb paresis. Another study investigating the relationship between trunk muscle and spinal tract using transcranial magnetic stimulation reported that the magnitude of ipsilateral and contralateral motor evoked potential were approximately equal, and these findings suggested that trunk muscles received bilateral innervation, and that could explain why trunk control is impaired significantly post-stroke and affect the overall function. What happens in the trunk after stroke? Trunk impairment after stroke characterized by muscle weakness, reduced proprioception, and impaired intersegmental coordination, which lead to decreased weight shifting ability during sitting and standing, and decreased dynamic stability, and increased trunk displacement, and increase the use of trunk compensatory movement. And this increase in trunk compensatory movement reinforce the maladaptive plasticity and lead to poor rehabilitation outcomes. So given the importance of trunk control in the recovery post-stroke, has trunk control received a sufficient attention in the published literature and guidelines? The UK Royal College guidelines recommended that people with impaired sitting balance after stroke should receive trunk training exercise. However, a systematic review and meta-analysis of 467 studies explain the component of the rehabilitation program post-stroke, and they found that the majority of the published literature focused on the rehabilitation of the upper limb and lower limb. And this mismatch between the guidelines and the published literature led me to ask, what about clinical practice? To what extent trunk function addressed in routine clinical practice in Saudi Arabia? And to answer this question, we distributed a national survey using Saudi Health Commission database to explore the use of standardized outcome measure among neurophysiotherapists. We only include neurophysiotherapists who treated stroke patients. And one of the outcome measure we investigate their use is trunk impairment scale. And as you can see, the result showed that about 24% of the neurophysiotherapists unaware of the trunk impairment scale. And a small portion, they use them in their clinical practice. But the good thing is that we received a positive clinician attitude toward using standardized outcome measure in their daily routine practice. And more than 80% of them, they found it useful in clinical decision making and good tool for communication between patient and physiotherapist. The major reported barriers for not using standardized outcome measure in their daily clinical practice is time constraint and limited resources. And these findings suggest that neurophysiotherapists in Saudi Arabia, they didn't ignore trunk impairment scale because they believe because they don't believe in their importance, but due to practical challenges. And most of the standardized outcome measure used in clinical practice, they score the performance of patient in terms of completion of the task. So if the participant completed the task, they will score 1 or 2. If they didn't complete the task, they will score 0. And this neglect really some of the other factors like compensatory strategies exerted during performance of either trunk impairment scale or upper limb activities. And that led me think about clinician, they need to distinguish between a true motor recovery and compensatory strategies exerted when performing upper limb activities. So in order to address this limitation, we conducted a validity and reliability study to use initial measurement units to measure trunk movement during performance of upper limb activities, and specifically during performance of the 8 tasks of streamline wolf motor function test. I will describe the 8 tasks briefly. The first task is to put the hand over the table. The second task is to move the hand from table over the box. The third task is to hold the can and bring it to the mouth. Task number 4 is to lift a pen from the table. Task number 5 is to fold a towel. Task number 6 is turning key in a lock. And task 7, pulling the weight toward participant by doing elbow flexion. And task number 8 is pushing the weight away from participant by doing elbow extension. We measure trunk movement during 8 tasks in all plans. And the result showed that using inertial measurement unit to measure trunk displacement during upper limb activities is valid and reliable tool. And we found that chronic stroke survivor exerted a compensatory movement higher than aged matched healthy control. Understanding the effect of intervention on motor function and whether this improvement in function occurred due to recovery of the lost motor function or the use of compensatory movement is vital to justify the treatment approach. So So after this, we was thinking, what if we improve trunk? What if we improve trunk function? Does upper limb performance will be improved as well or not? So we conducted a systematic review and meta-analysis to answer this question, and we include 17 studies. We have found that trunk impairment scale, trunk exercise showed a significant improvement in a very large effect size in acute, subacute, and chronic stage, either measured by trunk control test or trunk impairment scale. Unfortunately, none of the included study and published literature did measure the effect of trunk exercise on the upper limb function. Also, the majority of the trunk exercise done in the studies, they use the repetitive hour of training and require one-to-one supervision. The repetitive nature of exercise could decrease participant motivation and consequently affect adherence to the rehabilitation program. And in order to address this limitation, we think that technology development may address this problem by adding an interactive environment where a patient can practice the exercise on its own and interact with the auditory and visual stimuli given by video games. So that led to another study to investigate whether if there is any devices, any virtual reality, any technology used to deliver trunk exercise and stroke, and we conducted a systematic review to investigate the effect of virtual reality trunk exercise on reducing trunk impairment post-stroke. We exclude robotics. We only include studies that use virtual reality where patient practice by himself without aid from robotics. Only 6 studies published about using technology in trunk exercise. The result of the meta-analysis showed that virtual reality trunk exercise demonstrate a very large statistical significant effect on improving a trunk impairment as measured by trunk impairment scale. And the most significant result shown in subacute group. Despite these promising results, most of the technology used in the published literature, they used immersive virtual reality, which is impossible to be implemented in daily clinical practice due to their high cost, due to a large space required to be install these devices in clinic. Another thing is complexity of the device itself. So commercial virtual reality devices such as Nintendo, Xbox have been suggested as an alternative technologies. But the problem with the alternatives is that they require higher upper limb dexterity to be able to hold controller or a high level of function to be able to stand on a Wii balance board. Another limitation also is that these video games cannot be adjusted according to the participant cognitive or physical ability. So therefore, we think that we need a device that suits different disability level, either in terms of physical disability or cognitive disability. Then we design a feasibility study of using video games to deliver trunk exercise using inertial sensor. The same inertial sensor, I used it in the first study, I used it also to deliver trunk exercise. It contains 8 different games. And 8 different games, and we did assess the feasibility of these video games using Valido system in chronic stroke population. The outcome measure used for feasibility is PIADS, and for acceptability we did interview post-intervention. And also we measure functional performance in terms of trunk impairment, and we measure upper limb and lower limb using Figel-Meyer assessment. We measure balance using Berg balance scale, and we also did measure trunk range of movement during performance of the 8 tasks of streamline move motor function test before and after intervention. We design a program. Firstly, let me talk about the Valido system. Valido system is a wireless movement analysis training system. It includes 3 lightweight sensors, can be secured around the trunk using adjustable belts, and the exercise can be practiced either from sitting or standing. We decided the position of exercise according to the Berg balance scale. We design a program of 18 sessions delivered within a period of 6 to 8 weeks. Each participant will attend 3 sessions per week, and each session contains 5 games, a 45 minutes actual training. The video games, as I mentioned, can be practiced either from sitting or standing, and we decided the sitting position or standing position based on Berg balance scale. If participants have less than 45 in Berg balance scale, they will practice from sitting. If they have a higher score, they will practice from standing. And in the middle of the program, at 9th session, we reassess Berg balance scale and progress the exercise position. These patients on the left side practice lateral trunk flexion exercise, and the one in the right side practice a trunk rotation from standing. As I mentioned, each exercise not only progressed from sitting or standing. Each game have 3 levels of difficulty: easy, medium, and hard level. And when participants score a higher score in easy level or medium level, they will go to the other level. They practice the same game each session. This is the participant characteristic recruited from 2 sites, Southampton in the United Kingdom and Riyadh in Saudi Arabia. As you can see, we have different abilities from wheelchair to independent walker. The result of the feasibility using BIADS showed a positive impact on participants in all of the subscale: competence, adaptability, and self-esteem. A higher score is 3. And also the response rate was 30%, eligibility rate 44.5%. It's considered as quite low eligibility rate because we asked the patient to not receive any therapy during the interventional program. So this is one of the most important barrier for the participant, and the program itself is quite long, 18 sessions. In terms of adherence, 80% attended all sessions, 10% attended 17, and 10% attended 12 sessions. The participation using Pittsburgh rehabilitation scale showed a high participation, 4.2. There is no major adverse event aside from only fatigue and muscle tightness in the first couple of sessions. The interview showed a high acceptability rate among participants. They found it enjoyable and they found it useful in their functional daily activities. Some of them, they reported an improvement in bed mobility, and some of them also reported an improvement in standing up with a chair. And this is highlight the importance of motivation given by the video games. In terms of clinical outcome measure, there is an improvement in Berg balance scale, trunk impairment scale, and time taken to complete the streamline wolf motor function test. The upper limb and lower limb only show minimal changes. In terms of trunk compensatory movement during 8 tasks of streamline wolf motor function test, there is a huge reduction in the compensatory movement of 4 tasks. I'm going to remind you of these 4 tasks. Task number 1, putting hand on table. Task 2, putting hand over the box. And task 3, holding a can and bring it toward mouth. Task number 6 is folding towel. There is a huge reduction in trunk flexion when performing these tasks after intervention. Take-home message: trunk control is an important predictor of functional recovery after stroke and should be considered when designing post-stroke rehabilitation program. Trunk exercise is effective in reducing trunk impairment in individuals with acute, subacute, and chronic stroke. Video game-based trunk exercise may be considered to enhance engagement and reduce boredom associated with the conventional repetitive rehabilitation exercise. Some consideration needs to be taken into account by a clinician by considering the cognitive and physical ability of the patient when implementing these type of intervention. I want to acknowledge my team for their contribution in this work, Professor Badr al-Qahtani and Dr. Aqil al-Anizzi, and thank you for your attention.
Thank you very much, Dr. Noura, for this inspiration talk and informative information regarding trunk recovery for stroke. And thank you, our speakers, for your informative information, which was really interesting, and you were adding too much information to us. Thank you, our audience, our speakers, our invited people, and our students to attend this session. We meet our objective by the end, and we welcoming Dr. Mohammed al-Shahri to conclude this session. يعطيكم العافية.
شكرا لدكتورة شريفة محمد عسيري على إدارة الجلسة الثانية من اليوم الثاني لهذا المؤتمر، والتي حملت عنوان التقنيات الحديثة والتطورات الطبية في مجال التأهيل السكتة، في مجال تأهيل السكتة الدماغية. وأيضا كل الشكر للمتحدثين في هذه الجلسة: الدكتور محمد بن ناصر الشهراني والأستاذ محمد بن حسن الحربي، وأيضا الأستاذ عبد الكريم بن سليمان الحميد، والدكتورة نورة بنت عبد العزيز الهويمل. في هذه الأثناء نرحب بمعالي المهندس عبد العزيز بن محمد التويجري، وندعو سعادة وكيل الجامعة للدراسات العليا والبحث العلمي الأستاذ الدكتور محمد بن عبد الرحمن الشهري للتكريم. درع مقدم من جامعة المجمعة لكرسي الشيخ عبد الله بن عبد المحسن التويجري للأبحاث التطبيقية لحالات الجلطات الدماغية يتسلمه معالي المهندس عبد العزيز بن محمد التويجري. ثم نأتي الآن لتكريم متحدثين لليوم الثاني، وهم الدكتور عبد الله بن محمد الأحمري، الدكتور محمد بن أسامة الحيزان، الدكتور سعيد بن أحمد الغامدي، الأستاذ سعود بن محمد السعدون. الدكتور محمد بن ناصر الشهراني. الأستاذ محمد بن حسن الحربي. الأستاذ عبد الكريم بن سليمان الحميد. الدكتورة نورة بنت عبد العزيز الهويمل. الدكتورة حنان بنت حمدان الشهري. الدكتور عباس بن صالح المطير. وأخيرا الدكتور تركي بن فلاح المطيري. نأتي الآن لتكريم رؤساء الجلسات العلمية وهم الدكتور عبد الرحمن بن عبيد الحربي. الدكتور فيصل بن سعود الكثيري. الدكتورة دانا بنت محمد اليحيى. الدكتورة شريفة بنت محمد العسيري. والدكتورة ريم بنت محسن المطيري. نأتي الآن لتكريم أعضاء لجنة التحكيم لأفضل الملصقات العلمية. الدكتورة دانا بنت محمد اليحيى. الدكتورة وداد بنت مناحي العنزي. الدكتور مساعد بن فهد رايزة، تسلمها بدلا عنه الدكتورة ريم المطيري. الدكتور مشاري بن أحمد الزهراني. يسرنا في هذا الأثناء الإعلان عن نتائج تقييم الملصقات العلمية، والجوائز هي عبارة عن شهادة ومقابل مالي، حيث حصل على المركز الأول البوستر رقم 10 الدكتور رياض الشيخ من كلية الطب بالجامعة. حصل على المركز الثاني البوستر رقم 4 الطالب سعد العنزي من جامعة الحدود الشمالية. فيما حصل على المركز الثالث الطالبة تاله عبد الله من جامعة الملك سعود بن عبد العزيز للعلوم الصحية بالرياض. استراحة قصيرة لمدة 20 دقيقة، نعود بعدها لاستكمال الجلسة الثالثة من اليوم الثاني لهذا المؤتمر. نستكمل الجلسات العلمية اليوم الثاني لمؤتمر جامعة المجمعة الدولي للسكتة الدماغية. وقبل البدء في الجلسة الثالثة معنا ورقة علمية من الأستاذة وئام عقاب السالم، أخصائي أول علاج طبيعي في مستشفى الملك عبد العزيز التخصصي بسكاكا الجوف، وأيضا إضافة للعمل في الإدارة التنفيذية للتخطيط والتحول والمشاريع وتطوير الأعمال.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Today, inshallah, we'll be talking about mirror therapy, improving the motor and time functional ability of the upper extremity among chronic stroke patients as a single-blinded, multi-central randomized controlled trial. So, as we all know, stroke can cause aggressive impairments to the human body. Around 80% of stroke survivors experience upper limb impairments. More than 55% of those survivors carry their impairments more than 6 months. Despite the prevalence of the conventional physical therapy techniques, there is a need for an effective treatment strategy that can be easily administered along with the conventional physical therapy. A study done by Professor Salim Al-Atawi in 2021, he found out that 77.66% of Saudi physical therapists have used to use BOBIT as a neurological developmental therapy and places less emphasis on the upper extremity rehabilitation. And so to address this gap, we proposed during this research to evaluate mirror therapy as an easy-to-administer treatment to enhance the upper extremity motor function. Mirror therapy, apparently we use a mirror, and please do allow me to demonstrate how this works. I hope it's visible for those in the back. So basically, it's a mirror. We ask the patient to place his affected hand just below the mirror, just behind the mirror, and we'll be using the sound side or the non-affected side in front of the mirror. We'll ask the patient to keep focused on the reflection of his hand in the mirror. This will cause an illusion for the patient as if his non-affected arm is moving. So the reflection in the mirror looks exactly the same as his affected arm. With repetition, as much as we repeat, as much as we motivate specific neurons in the brain called mirror neurons, which are in the primary motor cortex. So our main objective was to find out the effectiveness of mirror therapy along with conventional physical therapy treatment versus the conventional physical therapy in improving motor and time functional abilities of upper extremities in chronic stroke patients in Saudi Arabia. So we hypothesized that mirror therapy would improve the motor and time functional abilities of the upper extremities in chronic stroke patients in Saudi Arabia. This study was a single-blinded randomized controlled trial. We included 38 chronic patients according to specific criteria, 19 patients in each group. This study took place in 3 different hospitals in Saudi Arabia, starting with King Saud Medical City, Prince Mut'ab bin Abdul Aziz Hospital in Sakaka, and finally Prince Sultan bin Abdul Aziz Humanitarian City. So as a procedure, both groups have received 45 minutes of training 3 days a week for a period of 6 weeks. For the control group, they have received total 45 minutes of conventional physical therapy, while the experimental group have received 30 minutes of conventional physical therapy alongside with 15 minutes of mirror therapy. For the initial assessments, we have used mini-mental status examination alongside with modified Ashworth scale. For pre and post-intervention measurements, we have used Figel-Meyer assessment for the upper extremity, also Wolf motor functional tests, both time and functional ability. This study was registered on clinicaltrial.gov with the shown ID. As a result, the participants' average age was 54.97 plus and minus 7 years. Among them, the majority of the participants were male with a percentage of 68.4%, and the ischemic strokes being the most prevalent in our participants with a percentage of 73.7. Coming to our first outcome, which was Wolf motor functional test regarding the time, which basically means how much time did reduce for the patient performing or applying his exercise or given tasks pre to post intervention. As we can see, for the experimental group, we found significant improvement pre to post intervention in comparison to the control group. Coming to the second outcome, which is also Wolf motor functional test, but this time for the functional ability. And basically, functional ability means how did the function or the movement, we measure the function efficiency, consistency, and steadiness. Again, the experimental group showed significant improvement comparing pre to post intervention in comparison to control group. Lastly, the Figel-Meyer assessment for the upper extremity. Again, experimental group showed significant improvement comparing pre to post intervention in comparison to control group. For the mean differences, pre to post interventions, experimental group versus the control groups, among all three outcomes, as we can see, apparently, experimental group showed significant improvements in comparison to the control group. The present research is one of the unique studies conducted on stroke population in the Kingdom of Saudi Arabia. And we have found interesting improvements in the experimental group on upper extremity impairments assessed by our outcome measures. The combination of conventional physical therapy and mirror therapy provided superior improvements in chronic stroke upper extremity function in comparison to the conventional physical therapy alone in the control group. So, current study has compared 11 studies' effect of mirror therapy on stroke subjects with the same outcomes. As any other study, some studies showed similar outcomes as ours, while others showed different means. These differences were possibly due to the following reasons. Most of them considered acute and subacute participants, whereas current study considered chronic cases only. Most of the studies did not consider the whole FMA score as we did. The duration of intervention in most of the studies was for a period of 4 weeks, whereas our study had 6 weeks. And finally, as in most comparison studies, the current studies experimental group combined both conventional physical therapy with mirror therapy. Coming to the limitations and the future recommendation, the study focused solely on applying mirror therapy to the upper extremity. So future studies are advised to investigate its application to the lower extremity as well. As our study focused specifically on individuals with chronic stroke and delivered the intervention within a hospital setting, which contributed to a relatively small size, future researches could explore administrating the intervention in community and home-based settings to facilitate larger size sample. While all participants had chronic strokes, this means more than 6 months, details such as clinical data, lesion location, stroke type, and exact time were not recorded. That's why this could limit the specificity of the findings, and future studies should include those variables. In addition, this study did not include post-study follow-up, which should address future research to evaluate the maintenance of the function after treatment and in community-based settings. As a conclusion, we can say mirror therapy is a low-cost, non-invasive, high-efficient approach based strategy to enhance functional ability and independency while optimizing rehabilitation outcomes and healthcare resources as aligned with the Saudi Vision 2030. Those are our references. This is our published paper for those who are interested to read more. Thank you so much for your attention.
بعد هذه الورقة العلمية نستكمل الجلسة الثالثة من اليوم الثاني، والتي تحمل عنوان التمريض، التغذية، صحة الفم والوقاية من السكتة الدماغية، وذلك برئاسة الدكتورة ريم بنت محسن المطيري. فلتتفضل لبدء الجلسة.
Good afternoon and welcome to the third and last session of today's conference. We have an excellent lineup of speakers. I'm honored to introduce them. First, Dr. Hanan Hamdan al-Shihri, Assistant Professor of Critical Care Nursing. Professor Abbas Saleh al-Mutair, Professor of Critical Care Nursing and Research Center Director at Al Musa Health Group. Dr. Turki Falah al-Mutairi, Assistant Professor of Oral and Maxillofacial Surgery at المجمعة University. Last, Professor Haroon Chaudhry, Consultant Neurosurgeon at Hudson Neurosurgery. First, presenting Dr. Hanan Hamdan al-Shihri with the title, The Role of Nursing in Stroke Patient Care.
السلام عليكم ورحمة الله وبركاته. إن شاء الله معنا اليوم نيرسز. كم العدد؟ إن شاء الله في عدد. I'm going to talk about nursing role in caring for a stroke patient. So we have two types of a stroke patient, as you know. We have block or bleed, ischemic or hemorrhage. So each type, we work with a definitely different protocol in each hospital or in each, worldwide. So we will talk about the prevalence. So stroke is a second leading cause of death worldwide. However, it's the third leading cause of disability worldwide. around 50 million people per year affected by stroke. Approximately 1/3 of stroke cases are fatal. So about 1/3 of survival living with disability. So what is our rules as nurses caring for patients with a stroke? Any idea? As a nurse, I will talk about comprehensive care. And comprehensive care for nurses is multi-dimensions. So by the literature, we should focus in early recognition first. Prevention of complication, rehabilitation support, and patient and family education. So for early recognition, as a nurse, we should think more about assessment. So when we receive a patient with a stroke, we should assess their Glasgow Coma Scale, NIH stroke scale. Also, vital signs is important for a nurse to document also and to do, their analysis. Maintain air patency is very important for nurses and critical care nurse. Why? Why do we think about air patency as a nurse? It's a question for nurses. No one?
Any answer from the audience? Please raise your hand if you have an answer. Okay, we can continue.
It's very important for us to think about airway because of the disability and the weaknesses of the muscles that are affected by motor response. So it might be there is like aspiration. Maybe it's very difficult of breathing for patient with a stroke. So the second things we should think about neurological assessment or monitoring. So as a nurses, we should recognize the patient deterioration. So sometimes patients coming with a stroke, they deteriorate within like seconds or minutes. Assess a level of consciousness. People size and people assessment is very important for us, including motor functions, and all of these including in Glasgow Coma Scale. Motor for increasing intracranial pressure, especially for ICU nurses or nurses who is working in critical area. So we should also observe the hemorrhage. If the patient gets any hemorrhage or bleed from anywhere. Prevention and complication for nurses is very important too. So the secondary complication could be happen for a stroke patient. Also prevent aspirations, pneumonia, like what we said before. We should care about air patent. Swallowing assessment for patient is important. Reduce pressure injury. Stroke patients, the mobility is minimized for them, so we should think about how could we prevent injury by reposition for a patient who is diagnosed with a stroke. Prevent deep vein thrombosis is one of the important measures that we do for a patient with a stroke. managing bladder and bowel dysfunctions. So there is a severe weaknesses in some part of the body. So this is one of the important things that we also recognize and assess while we work with patients with a stroke. Monitor infection and electrolyte imbalance, and report to doctors with any abnormalities. Infection could be happen for patients with a stroke, especially oral infection. Rehabilitation and function recovery. Today we cover the majority of rehabilitation and function recovery by my colleague in the first section and second also. So the most important things is assist with activity daily living as a nurses, and also supporting them during the early rehabilitations, either by education or either by helping them with anything regarding the mobility. Supporting cognitions and communication recovery. So if the patient has a difficulties of communications, we should be the assistant for them during their disease. Working with a stroke patient is very important as a multidisciplinary. It's not only nurses, not only physician, not only physiotherapist. We should work as a teamwork. So here one of the study done based on home-based continuous rehabilitations nursing can enhance recovery after discharge. So this is study done according to evidence-based, and unfortunately there is no any country from Middle East. However, we have some country from Asian and from Western region. What they got and what is the result that is important for us to apply for nurses. We have 7 dimensions we should think about it. The first dimension, rehabilitations management. And this management is important to do as interdisciplinary team. So we cannot do anything alone as a nurses in this first rehabilitation management. We have to have a teamwork because we have multitask, multi-knowledge, multi-information, multi-applications in the practice, especially in home-based practice. The second one, rehabilitation assessment. We should assess cognitive assessment, neurological assessment, communication assessment. All of this assessment is very important for us as a nurses. Motor function training, like my colleague in the morning, they talk about different type of function training, like treadmill, swimming, like walking, cycling for a patient. All of this function training is very important for a patient at the moment. And sometimes by evidence, they said it's 3 times to 5 times, 3 times to 5 times per week, 30 minutes on treadmill is one of the effective for a patient to improve their disability. Motor activity daily living training, also one of the important things that we should do. As a nurse, we are working always with physiotherapists, especially, for example, from my background, I'm working in ICU before, so we work together. Sometimes the physiotherapist is not staying longer with the patient, but they give us some information that we should do it for a patient during their staying. It's quite similar to when we do it in the home care. So assisted devices support. Today, there is talk about mirror. There is a talk about what is that? Sorry? It's FE. What is the doctor that he's talking about? Stimulations advice. It's like stimulation advice that's used for patient in lower limb or upper limb. It's very important for us to include it in assisted device support, especially for patients when they are in home. Psychological support. We like to integrate psychologists in all the care to improve our quality of life, either for stroke patient or any chronic illnesses. So they are very important to improve the psychologist of patient by sometimes by literatures. In this study, they use full-mindedness, they use also yoga, they use also, there is a Chinese treatment or method, Chi Chai, they call it. So it's one of the methods that they use it to improve the psychologist support. Risk management, of course, we should think about patient safety in anywhere, either in the hospital or they transfer to home. So the safety is very important as us for nurses to think about it. If the patient in the home, we have to think about the clean and clear environment and safe environment for a stroke patient. Psychological and emotional support, it's including in the 15 study or in the study before. However, as a nurses, we should provide emotional support and reassuring. Communications, compassion communications, very important for nurses to talk with the patient and improve their psychologist. Assess the post-stroke depression and cognitive changes. Cognitive changes is also very important for us to assess. Promote coping strategies for patients, especially to motivate them. Like one of our colleagues, he talked about patient dignity today is very important for patients. They think about how they could really move very fast to do their daily activities, like toileting. It's a part of our dignity as a Muslim people. Not even Muslims, about a human. Supporting family members and caregivers is one of our rules for psychology or psychological support. Talking to the family, reassure family, educate family is very important for nurses. So here, one study done also about nurses' role in psychology health, managing after stroke events. And it's addressing mental well-being for people after a stroke. So this study, or this evidence, is included to screen using validated tools for psychology, educate family and people around, also patient, either caregiver, because it might be different caregiver than family. Appropriate pharmacological management. We should think about what is the type of medication. How could we educate patients about this type of medication that they talk? Psychological and psychosocial intervention is very important for us. And sometimes we have a limitation in our rules as a nurses. However, like what I told you, it's a teamwork. So if you have anything that you cannot do, so there is a psychologist, there is a psychosocial, social worker that you can just counseling them or involve them in your work. Referral to social services, and it's essential to have a support system like social worker. Post-stroke care should be a comprehensive, like when I start this talk. It's a comprehensive care and interdisciplinary team. From my point of view and from my background of my specialty, it's very important for us to think about palliative care in this moment. Nursing strategies for post-stroke rehabilitations. We have 4 major strategies. Early mobilization is very important during the hospital setting or during the time of when the patient is inside the hospital. Patient education is also very important. However, if the patient cannot understand what you say, you have to teach also the caregiver or family. Medication adherence is very important to be familiar how this patient could take this type of medication. Did they have assistant to do that? Did the caregiver know what type of medication is very important, when they can take it? What is the time also? Coordinations and multidisciplinary care is very important. Always nurses, I can say, are a leader for multidisciplinary care. So they are the one most responsible to approach the patient and family and coordinate the care for patient. Patient and family education is also one of our important rules as a nurses. You have to recognize like the warning signs of a stroke and tell them what is this sign, when the sign is started, what they will do and how they will do and what they will, how they can respond for it, especially for the secondary complication. Educate about medication adherence, provide guidance for lifestyle and modifications of movement like diet, lifestyle, training, smoking cessations. All of these things is one of our rules. Prepared patient and caregiver for home care rehabilitation needs. It's very costly to think that if we cannot mobilize the patient and change or transfer the patient from hospital to home. So here there is one studies about transition care from home, from hospital to home, and it's to explore the attitude and the perception of clinical practice or staff regarding transition patients from hospital to home, especially specialized in stroke patient. This is a study done in China, and it's a semi-structured interview qualitative study. So the results say what? Recognizing the importance of translations care. The thing that nurses, they don't know what is the meaning of translations or transitions. They don't know. In this study, there is a lack of knowledge for nurses. A physician in this study, they approach a very high knowledge. However, nurses are not. Challenges of implementing translation from hospital to home. What is the type of strategies? How could we discharge the patient and go to the home? Did they do the prerequisite for the context, the home? Is it safe for patient to go and to transfer patient to home? Transition is one of the important things that we should think about it. Here, the need for education. It's not for a patient. This one is for healthcare provider, for nurses. Also, there is a demanding that they need advanced nursing practitioner in home care to cover the gap. So here, build the future through education. So if we have a lack of knowledge, still, by the way, all the study is updated, 2025, 2026. So, and still we have a gap in our knowledge. It's very important. Here is the second study done in Palestine, and still we think about that we have a lack of knowledge. And also, I can see here 46% show a positive attitude. How about others? So there is a need for a knowledge and attitude to approach care for patient with a stroke. Finally, I conclude my work and my talk today for nurses and for everyone. Early recognition is very important and triage. Acute neurological monitoring and protocol activities is very important. Family and patient education is very important to prevent the secondary complications. Psychology, screen, and mental health support is one of the major. Coordinate discharge plan and translation care. rehabilitation, support, and follow-up care. Conclusion, nurses play a crucial role in stroke, providing early assessment, effective treatment, rehabilitation support, and patient education. Here is my reference. Thank you very much.
Thank you, Dr. Hanan. Next, Professor Abbas Saleh Al-Mtair presenting using artificial intelligence in a clinical decision-making toward more accurate and efficient care.
السلام عليكم. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. شكر لله أولا، ثم للجنة المنظمة وللجامعة جامعة المجمعة على الاستضافة الكريمة وحفاوة الاستقبال. Over the next like 20 minutes, I'll be talking about the using artificial intelligence and AI in terms of clinical decision making and how it can actually help us in terms of clinical decision making. I'll go through a number of breaking through studies where the would actually shape the future of medicine in terms of clinical decision making, in terms of making diagnosis, in terms of the therapeutics, and over the last 10 years I've been working in research and how can we integrate research into and data into clinical decision making and AI, and how can we integrate all of them in terms of developing an AI assisted systems which would help us in terms of clinical decision making. I think this is the future, and everybody actually senses that this is the future of medicine and future of everything, where we can utilize AI. I'll be giving an overview of the machine learning and AI, and also the role of AI in terms of clinical decision making. Also, major advancements in healthcare, like for example the medical imaging diagnosis, triage and emergency, and also the pathology and disease prediction. How can AI utilizing machine learning and AI and data as well in terms of helping the decision making, genomics and personalized medicine as well. Also, towards the end, I'll be highlighting some of the companies which actually uses AI and maybe shape actually the future of AI in terms of clinical decision making. Also, we'll highlight some of the initiatives here in the Kingdom of Saudi Arabia, which aligns actually with Vision 2030. So when it comes to the AI, it's actually, the components of AI in terms of clinical decision making, we do have actually to have a machine learning, which is mainly an algorithms that has patterns from data that we actually integrated within it. And then we have the NLP, which actually utilizes the notes, for example. They do analyze the notes that we usually use in terms of electronic health records. Computer vision is very important, and making sure that we actually integrate it within it. Robotics, indicated by a very nice presentation earlier this morning. Expert system and also predictive analytics is very also important. So if we will be able, to integrate all of those components, then it's actually going to help us in terms of, making the decision. Actually, it's only a tool, and it won't replace us again, but maybe in the take-home message it will highlight how can we utilize it. So when it comes to the role of AI in terms of healthcare and clinical decision making, so we do have the three components. For example, the diagnostics, the patient monitoring, and the drug discovery. So when it comes to diagnostics, it's to actually help us in terms of early detection of the diseases, the risk factors through the prediction, for example. And I'm going to highlight a number of studies breaking through studies also. Devices equipped with AI can also help in terms of monitoring the patients, for example. So it depends on the data that we usually integrated within it. And also the drug discovery. Those who work with I mean, drugs and drug discovery, AI is very important. And actually it can accelerate, I mean, the drug discovery through the AI. For example, through predicting the behavior and modeling outcomes. We do have what we call it real-world evidence. And real-world evidence, those who work through research, you know, we do have a data that's which we actually collect within our health records. You know, the pharma companies and you know, would like to know, for example, the progress of any medication. How is it going? I mean, in terms of, I mean, the side effects, in terms of the action of that medication. So they usually utilize the data which is available in health records in order to actually make sure that, you know, how the drug is doing in terms of, I mean, efficacy and safety. So the significance of AI, it's actually very significant, and this is sensible, like in terms of efficiency, you know, and if we would like compare it, for example, with us as a human. Diagnosis, making the diagnosis very efficient actually in terms of making the diagnosis compared to us. Personalization, you know, personalized medicine also through genomics and pharmacogenomics, predictive analysis. You know, AI can actually predict what shall we do, and the accuracy is very high actually. So, and this would save us actually time, custom treatment, and I mean, we usually have to utilize the data that we have. So any predictive, any diagnostic can be actually done based on the data that we have or we keep in our health records. And this is very, very important, where we will be able to make a customization in terms of a treatment based on the data, and the accuracy is very high. As I told you earlier that I work in research for the last 10 years, and you know, data is the new oil. In the future, if you own data, I mean, actually AI does not work with data, so without data, sorry. So it needs data. The more you feed it with data, the more you will be able to have more accurate you know, outcomes. So in terms of, I mean, like, if we'd like to apply the AI in terms of clinical investigation and clinical in decision making, it can help actually in deep learning of, for example, in radiology. And there is a saying where AI can replace radiology in the future, or radiologists, sorry, in the future. So risk prediction, also, if we'd like to make a prediction in terms of risk, who will get the disease or who will not get that disease. Also, natural language processing, NLP, is very helpful actually in terms of analyzing the notes, the clinical notes that we usually keep in our health records, and also predictive analytics for progression of the disease is also very you know, efficient. So if I would like to compare before AI, you know, a very small comparison before AI and after AI. So when it comes to the speed of diagnosis, if we would like to rely only on a human, it's very slower as compared to AI. And also, you know, it can be variable actually. It depends on the specialist. It depends on the human, you know. But in terms of AI, it actually improves the pattern through recognition. It utilizes thousands and maybe millions of images, millions of data, and then it can give actually more accurate results or outcomes. Consistency, again, before AI, it's, you know, consistency depends actually in the human. It might be good, it might be not. You know, it's variable actually, while it's more consistent if we would like to use AI. And also in terms of access to expertise, it can be limited. You know, we need very good expertise in terms of working with a number of diagnoses, like for example, and this needs a time, a location, while, you know, AI is, you know, everybody has an access to AI. And then they can actually use it and utilize it very well in terms of clinical decision making. Workload for clinicians, you know, if we work alone without, if I'll bring us, you know, if I'll take us back, and this is a question I asked actually before, when I was collecting the data for a research that I was doing. Will you go back and work without AI? He said, no, I cannot actually go back and work without AI. So this is, it actually reduced the routine and the burden actually on us as a clinicians. And also early detection. It's very efficient in terms of early detection, and also it improves our, the detection also. Human error is very high in terms of, false negative, false positive without AI. However, this with AI can also be reduced. Clinician explains reasoning, and while it's actually, AI models are like black box and need explanatory tools, and also higher long-term and cost in terms of we would like to depend only on a human being, and with AI, I think the cost is much less. Data use actually depends on data. I mean, if we would like to use AI, heavily use large data sets. Role of a clinician is with AI is actually oversight, validation, making sure that you validate the results that you get out of it, and final decision making is also supported. So the final decision will be made by the clinician, but it has to be supported by AI, instead of the only decision maker is the human. So this, over the next slides, like 10 slides, I guess, or like 5 to 10 slides, I'm going to highlight some of the major advances in terms of clinical decision making. Like, for example, triage. When it comes to triage, the use, patients' input, data collection, and also they process them into AI utilizing algorithm, real-time feedback or evidence, NLP, like, for example, the notes, and then they come up with a triage decision and improved ED outcomes. Where also, again, before it was depends on the judgment and the pressure of the clinician. It's more consistent with AI, very consistent. Also, the decision without AI can be delayed. However, it can be quick, and red flags can be actually raised faster with AI. ED, we know that working in the emergency department is very crowded. And manual sorting of the patients in terms of triage, it might be very hard if we do it manual. This, if we would like to use AI, and automated prioritization is very also efficient. Resources allocation with AI is much better. Missed red flags is possible actually if it's manual, while in AI it can be also reduced. While also, when it comes to radiology and imaging is also very efficient. Workload is very high in terms of without AI, but with AI it's actually faster. Sometimes they miss diagnosis, but with AI, everything is enhanced and detection is consistent. And also, doing it manual is very, time consuming, while automation is very important in terms of using AI, and also delays as usual without AI, but critical scans instantly can be done with AI. Now, this is a groundbreaking research using AI. For example, a new research which was published in 2023, a new AI model was developed of evaluating cardiac function and identifying signs of VHD, which is the valvular heart disease and chest X-ray. It showed a very good outcome where they were able to detect, like, for example, the accuracy was more than 86% if they, utilize the model that they developed through AI compared to the manual. Also, in terms of detecting tumors, also where they will be able to, for example, especially deep learning models like conventional neural network CNS. It's a revolutionary where they can use X-ray, CTs, MRI, pathology slides in order to analyze the mammograms, and also identify micro classifications through the use of the AI. And this can be actually missed through a human compared with AI, and this is also another breakthrough in a study or a model through the AI. Again, you know, self-taught AI detects disorders from like a head scan. This is a Chinese company where they were able actually to develop a self-taught deep learning system which can detect 4 different conditions, including stroke, brain hemorrhage, brain tumors, and skull fractures through the through the AI model, and the accuracy was around 96%, which is very high compared to human. Also, AI can also detect cancer. Mainly, there are so many applications in terms of AI with cancer. Also, unlike the current approach, this company requires just one low-chest CT scan to predict lung cancer risk, which is, you know, a risk score between 1 to 6 years after screening. So it's only, I mean, it's a risk score. It's not a diagnosis, but it would actually give a hint whether this patient, for example, might develop a cancer in the future or not, in order to keep an eye on that patient. So and do the needed. Also, you know, a Google AI mammography, where they and the AI had a group like, I mean, they have around 80,000. Was published in Lancet Oncology journal, where they showed that actually 20% more cancer detected than the radiologist-only group. So they had around 80,000 women mammograms. They cohorted them through 2 groups. The first group where the diagnosis was made by the radiologist, and the second group was made by the AI, and they were able actually to show that actually the AI model was able to detect the diagnosis better than the radiologist. If I would like to compare between the 2 pictures, the one to the left can be actually detected, but the second one, it might be not be able to detect it by radiologists, and therefore, AI more capable of doing that one. Also, in terms of pathology, again, it's very helpful in terms of pathology, efficiency of pathology workflows, and identification and quantification of cell and structure and tissue samples is very efficient if we would like to use AI. This is another study. And also, a calculator by Cleveland Clinic, another IBM Watson Surrey Health, where they will be able to predict the health risk by analyzing a wide range of health data. Again, they by the training, the more we feed data into the calculator, the more we feed data into the AI, then they will be able to work more efficient. And it has shown actually 25% more heart disease from a data set sample of cases it had never been seen before with the work of the data. Genomic and pharmacogenomic and personalized medicine. For example, AI algorithm identified a specific mutations linked to cancer, enabling targeted therapies, like, for example, the Google Deep variant. And again, pharmacogenomic also a personalized medicine where they will be able to make sure that actually the medication is being prescribed is actually working with that patient or not. What this is, which actually minimize the adverse effects and maximize the efficacy and the safety of the medication being prescribed to the patient. These are some of the companies which may actually change the healthcare future. A total, I think, of 10 companies, international companies, which utilizes AI, and they've come up with AI models and a product which can be used actually in terms of clinical decision making in the future. Well, when it comes to Saudi Arabia, we know that there are so many work is going on in terms of AI, Now, one of the strategic goals actually to focus on AI here in the Kingdom of Saudi Arabia, and it aligns actually with the Vision 2030 investment, like more than 40 billion US dollars is being invested in AI and coming up with AI technology. And this is going to be led actually by Sadaya. Well, and these are some of the initiatives that I came across here in the Kingdom of Saudi Arabia. For example, King Abdullah, KAXT is collaborating actually with Sadaya in terms of coming up with mini-GPT MED, which is an advanced vision integrated AI language model, where they will be able to identify more than 14 diseases. And also King Faisal Specialist Hospital, they have a very good data actually in terms of genes and genetic. So they, genome sequencing, and they come up with AI to generate the CAR T cells for cancer treatment, and they conducted more than 7,000 whole genome sequencing tests. Also, Sadaya, they partnered with King Khalid Eye Specialist Hospital to develop Inaya, which is a solution to detect diabetic retinotherapy, retinopathy, and also Sahha Virtual Hospital. Also, they work with South Korean health tech firm in order to provide also AI-powered solutions for breast cancer and tuberculosis screening, again, which can help actually in terms of decision-making. Also, KAXT, King Abdulaziz City for Science and Technology, has developed an AI system segmented brain tumors for improved accuracy of MRI. These are some of the initiatives actually in Saudi Arabia. There is a Saudi company which is, the Mid-Lana AI, which is an advanced artificial intelligence system which integrates between actually the hospital information system, the HIS, and also the health record system in order to make the decision and develop, in terms of the diagnostic downtime and also the clinical data review time. And they have, the outcomes of that AI model has shown, 3% faster clinical workflow efficiency and 99% adherence to evidence-based protocol when it is integrated within the healthcare system, or if it is integrated within the AI model. Now, this is my final words, enhancing accuracy and efficiency. If we would like to use AI in terms of decision making, it actually supports us as healthcare professionals, in terms of healthcare professional, and making sure that, whatever decision we make is based on data and data driven, and also improve the patient's outcomes through making sure or utilizing whatever AI model is available to us, and also making healthcare more accessible to us as a healthcare provider. Now, will it replace us? No, it will not replace us, but I think, and this is my final word, those who will use AI will replace those who will not use AI. Thank you very much. Thank you.
Thank you, Prof. Abbas. Next, Dr. Turki Al-Mtairi presenting oral health and its impact on post-stroke complication.
Assalamu alaikum. So, today I'm going to talk about oral health and its impact on patients' post-stroke complication. So, we'll start with very simple questions. Are we underestimating the oral health in stroke outcome? So, increased evidence suggests that oral health can contribute to malnutrition, pneumonia, and eventually mortality. So today I will review the biological mechanism, global evidence, and the clinical strategies for integrating oral health care into stroke pathway. So stroke, we know it's a major health challenge, over 12 million annual cases. Nearly 1/3 of these cases develop infection, and pneumonia is the most leading cause for death. So the relationship between oral health and stroke is bidirectional, which means before the stroke, periodontal disease promotes systematic inflammation. And after the stroke, we have autoimmune response, and that can weaken the oral cavity. So basically, it's like a self-cycle, perpetuating inflammatory response. Oral microbial dysbiosis play a very important role in cerebrovascular disease. So stroke patients prone to have higher periodontal pathogens, and following the stroke, we know we have these opportunistic bacteria such as Staph aureus, Candida, it's increased. So dysbiosis is linked to stroke prognosis and severity. Stroke, acute stroke-induced immunosuppressions, we all know that. And we observe reduction in lymphocyte, which means basically patients vulnerable to infection, and basically the host defense become very weak. So what happened post-stroke for oral complication? First, at the beginning, we have oral hygiene neglect. We might have some trauma due to the fall, tongue-cheek biting as well. Following that, you might develop xerostomia, saliva pH changes, Candida, biofilm accumulation. Chronic, at the end, patients can develop periodontitis, tooth loss, caries, and malnutrition. Dysphagia, and it's been covered very well and with my colleagues, it can affect up to 78%. So with bacterial colonization plus dysphagia, we have silent pneumonia become very highly likely. And at the end, mortality rate can reach to 65%. Malnutrition, half of hospitalized patients, then from a stroke, they suffer from malnutrition. We have oral contribute, poor oral hygiene, tooth loss, basically can lead to decrease in skeletal muscle mass, reduce activity, daily living, and the functional teeth becomes, to predict the recovery. Impact on quality of life. So we talk about the oral disease and can affect the quality of life. And it can be divided into major 4 components. Physical health, when you have weight loss, muscle wasting. Functional, that can lead to difficulty in eating. Psychological, we have social withdrawal, reduced self-esteem, and depression, and some patients, they reported embarrassment due to these complications. Economic, of course, the longer you stay in hospital, the higher cost. So multiple studies across the continent demonstrate the same pattern. So consistent finding, oral health, we know oral health deteriorates after stroke. And intervention and structural intervention can prevent these complications. So this is some of the evidence. And we can see Wigner et al. They implement systematic oral hygiene care. It's a cohort study. They implement this protocol and the result, reduction in pneumonia. Again, another study, they include dysphagia with oral hygiene as an intervention. And they reduce pneumonia from 28 to 7%. Stroke studies, they implementing comprehensive oral care as well. They reduce pneumonia incidence. Another RCT studies is very short studies, but it shows the quality of life. It's improved after implementing these protocols. Japanese study as well, they call it trade approach because they implement rehab, nutrition, oral care together. And the result shows increase in activity daily living and increase in muscle mass. Finally, last randomized controlled trial Taiwanese studies, they use oral health program plus swallow therapy, and they found out oral intake increase as well as nutrition. And it facilitates as well tube removal. So this is the recent meta-analysis that I could find. It's published in 2025. They looked through multiple papers and they include 15 RCT studies. The result shows no significant improvement in dental plaque index and no reduction in pathogen. And we can ask these questions: why individual study shows benefits whereas meta-analysis shows no effect? And this could be due to multiple reasons. First, the methodological issues. So first issue, because we have different interventions. There's no standard protocol for these studies. So each studies, they use different protocol. Varied control group, different outcome, and inconsistent follow-up. Second reason, the statistic, small sample size, underpowered, and it's make it very difficult for meta-analysis to predict clear signals. To put it in a clinical reality, we have individual studies, and this individual study is real-world effectiveness, and biological relationship is strong. For me, this is enough to, if it's applicable in a hospital, we can use it. Oral healthcare prevention programs based on the available evidence. This is the most important component. We have basic protocol, which is basically brushing, interdental cleaning, denture care. Pharmacological approach, when we include chlorhexidine. A professional dental assessment, scaling, regular dental referral. Caregiver training, it's very important and it's been discussed. So, tried approach, we talked about it. This is one of the, let's say, it shows optimal result. When you delivered these three interventions in rehab with nutrition and oral care, you have very strong association with increased activity daily living, increased muscle mass as well. Implementation barrier. So to implement oral health care, we have these barriers. First barriers, it could be due to the patients, due to the disease itself. When you have impairment motor, cognitive deficiency, lack of awareness. At the healthcare staff as well, we have a gap between the staff, physician, dentist, lack of protocol, and also the priority sometimes. It's different. Environmental level, inadequate equipment, insufficient staffing, lack dental professional. Based on the available evidence, recent guidelines and recommendation, oral health care should be embedded into stroke pathway. And we know it cannot be delivered alone. It should be delivered with multiple teams. At the system level, we have evidence-based protocol, 24 hours assessment. Dental team should be available, adequate supply, staff education programs. Clinical practice, comprehensive assessment, individual care plans, twice daily minimum, regular monitoring, and early dental referral. So this slide, it shows that you can't deliver the oral care alone. And it should be delivered with multiple teams. And we should have all the teams, dentists, physicians, nurses, and hygienes, caregiver as well. Future research and priorities, we know that there is a bit of gap due to the interventions or standardizing interventions, because we don't have very standards that we should follow. Maybe large-scale multi-center RCT studies with standardized protocol. This is the future research. I can finish up and highlighting these 5 takeaway messages. Oral health significantly deteriorate post-stroke. Poor oral health increase the risk of life-threatening, which can lead to pneumonia. Global evidence demonstrates a consistent pattern, all the same result. Tried approach, it shows optimal outcome. And then meta-analysis, it shows little or no effect, but individual study shows it shows a benefit. To conclude, interprofessional collaboration and evidence-based protocol are essential for patients' outcome. And this is my references, and thank you.
Thank you very much, Dr. Turki, for this interesting speech regarding oral care after a stroke. And we welcome our next speaker, Dr. Haroon, to present his topic.
Thank you very much. I know it's late in the day, so I'll be quick about it. I'm from New York. I can talk fast. I think it says a lot about the quality of a meeting to see how many people stay until the end, but I won't abuse that. I'm going to talk today. They asked me to give another brief presentation about a topic related to stroke and how we can improve quality. So I was thinking about this, and one of the things which came to my mind was how often are we treating a stroke when it's not a stroke, and what are things that mimic stroke? Could I get the first slide? Hello? It's not. Is someone, hello? Is someone working on it? They asked me to wait a minute. So while they're getting that set up, I'll just mention to you, I did my neurology in London at Queen Square, and I was on the, thank you, I was on the multiple sclerosis service. And multiple sclerosis is a great mimic. It can imitate anything. And I became very fascinated with the whole idea of diagnoses that are difficult to make. And so one of the things I want to talk about in terms of improving stroke care is to give an example of something which might mimic a stroke, but might be something else. So just to get to it, this is a 42-year-old patient who had a history of neck pain for 3 months. He had a pneumonia, he went to an outside hospital, and they detected a subtle radiographic abnormality. I'll show you a CT scan. The medical students may not get this, but I think most of us who treat imaging realize that something is seriously wrong here. The patient's odontoid is touching his lamina. At this point, the patient is completely neurologically intact. And you might say, how's that possible? There's no space available for the spinal cord. And that lies the first lesson, and that is all imaging has to be considered in multiple planes. According to this, there's no space behind the odontoid for the spinal cord, but if you look at an axial section, you see, oh, there's a space for the spinal cord to be on the side. So this patient actually happened to be deaf and mute from birth. And his father was telling the story and giving the history when they transferred him over to me. He said he knew there was something wrong on the CT scan when 2 people put his son into the CT scanner and 10 people took him out. And they called and they transferred him over and said, how fast can you take this patient? They actually sent him over from another state by helicopter. When the patient arrived at our hospital, unfortunately, he was no longer neurologically intact. He now was completely plegic on the right side. 0/5 in all muscle groups, arm and leg. And unfortunately, because this patient was deaf and mute, he used sign language and he wasn't able to communicate, even though he was clearly wide awake when you look at him. He also had his neck flexed and rotated in a cock-robin position. So, of course, because there was a major dramatic change in neurologic exam between his transfer, we got some new imaging. So we got a CT scan at our hospital, and the corresponding image to this is here. So you can see clearly it's quite loose in terms of his spot. C1, C2 is mobile, and that's clearly not good for him. We need to know why he's neurologically impaired. Obviously, we can suspect it from this, but MRI scan will give a much better impression. And you can see right here. Yesterday, we talked about lab values, which are scary. This is an MRI, which is scary. Just take a look at his brainstem and his cervical medullary junction, absolutely squashed. You can also see infection anterior to the spine right here, where there's a retropharyngeal abscess. So now we have a patient who has a deformity. He's rotated, flexed. He has severe cervical medullary junction edema and bruising, unclear, and it's presenting with a hemiparesis. Now, of course, neck pain, you might think carotid dissection and hemiparesis. We couldn't assess his speech because he's been mute since birth, but he didn't have facial asymmetry. So we looked at this, and this is pretty clear that this is where the deficit is coming from. So I just want to show you how we approach treatment of this patient. So he came in with his neck flexed, bent forward like this, and we got some imaging. Of course, we patted him and protected him so he wouldn't move because we know that his C1-2 complex is very unstable. So we obtained CT scanning, and I'll show you a 3D reconstruction of the CT scan, which will show his deficits. This is how he was. If you look at the CT scan, you'll see that he has a C1-2 subluxation and stretching of the vertebral arteries. His odontoid is up against the lamina, and he has posterior migration of the lateral mass on the left, and he actually has a jumped lateral mass on the right side. Now, even though it looks like you can just simply reduce this, I did not want to stretch the vertebral artery anymore to get it in place. So we had to study the three-dimensionality a little bit better. 3D reconstruction allows us to see that the right C1 lateral mass is anterior to the C2 lateral mass, or superior articular surface. That's why he's rotated and flexed. From posterior, you can see that the odontoid is abutting the lamina. And when you look down the canal from the top, you can see a little bit of calcification. You'll see in a second. In the middle of the canal, and you see the odontoid there in the middle of the canal. So I did not want to manipulate him at all until I got him decompressed. So the plan was we intubated him in this exact position, put him in pins, turned him prone in this exact position, exposed it in this exact position, and then immediately did a C1 and C2 laminectomy to give the space for the spinal cord and cervicomedullary junction. Now I wanted to reduce him, but the problem was his jumped facet on the right side. The C1 facet was in front of the C2 superior articular surface. I did not want to distract that vertebral artery, so what I wound up doing is doing an osteotomy under the microscope of the superior surface of C2 and the inferior surface of C1, and that allowed me to, without additional stretch, rotate C1 back into position. Now he's decompressed, back in position. We got to hold him here. So I did an occipital cervical fusion, posterior instrumentation to hold that in place. So with that, he still had a pretty profound deficit, and some of his compression was from the odontoid, which is now in the proper space, but there's a lot of pus around the odontoid and anterior compression. So this is a CT scan immediately after the surgery. You can see the staples in the back. There's a drain in there and some of the bone graft material, but he still had soft tissue around the odontoid. So I did a transoral surgery, came in from the front and through the mouth, removed the odontoid and surrounding soft tissues, decompressed the cervical-medullary junction. He wound up having a tracheotomy for 2 weeks just because with all the retropharyngeal pus, we were a little bit concerned about extubating him, so we put in the tracheotomy. That was reversed after 2 weeks. And then he went off to get rehab. And he left the hospital, of course, hemiplegic, and then with his tracheotomy, went to rehab. We have phenomenal rehab where we worked, and they did a good job with him. He came back to see me, and this is a patient at 6 weeks after the surgery. You can see he's now able to move around. And he also has fairly, not just full movement, but he has fairly fluid movement in that he can move around, walk around. And he was able to resume many sports and other activities since the surgery. He's able to go back to golfing. He demonstrates his swing. He can throw a frisbee, he can throw a football. And his tracheotomy was reversed. So this is a patient that had a fairly profound deficit and very scary looking MRI, at least to my eyes. And fortunately, by rapidly diagnosing him and getting him treated, we were able to get a good result. And I think I'll leave it at that. Thank you very much.
So thank you very much, our speakers. Thank you, Dr. Hanan, and Prof. Abbas Al-Mutair, and Dr. Turki Al-Mutairi, and Dr. Harun for this interesting speech today. And we will conclude our ceremony for this conference. And thank you, our audience, our students, our guest speakers, and everybody here who make this gathering is very valuable and very excellent. And wish you all the best, inshallah, in the future, and see you, inshallah, in the coming events in Majma'ah University.
كل الشكر لجميع المتحدثين. الآن قراءة التوصيات النهائية لهذا المؤتمر، ويقرأ التوصيات الدكتور عبد الرحمن بن عبيد الحربي عميد كلية الطب.
السلام عليكم ورحمة الله وبركاته. شكرا على حضوركم الزملاء الكرام، ونختم هذا المؤتمر القيم في مجال السكتة الدماغية بالتوصيات التالية. أولا، يؤكد المؤتمر على الحاجة الماسة إلى استقطاب وتأهيل الكوادر المختصة في المجالات الدقيقة لعلاج السكتات الدماغية بما يسهم في رفع جودة الرعاية الصحية وتحسين مخرجات العلاج. التوصية الثانية، يدعو المؤتمر إلى تعزيز التعاون والتكامل بين برامج السكتات الدماغية في مختلف القطاعات الصحية من خلال تبادل الخبرات والاستفادة من المختصين وتوحيد الجهود بين القطاعات الحكومية والقطاع الخاص بما يحقق خدمة صحية متكاملة لمرضى السكتات الدماغية. التوصية الثالثة، يشدد المؤتمر على أهمية التخصصات المساندة، وعلى رأسها التأهيل الطبي والعلاج الطبيعي وعلاج النطق والتخاطب باعتبارها جزءا أساسيا من الخطة العلاجية الشاملة لمرضى السكتة الدماغية. التوصية الرابعة، يوصي المؤتمر بتوظيف التقنيات الحديثة وتطبيقات الذكاء الاصطناعي وفي خدمة مرضى السكتات الدماغية، سواء في التشخيص المبكر أو تطوير أساليب العلاج والمتابعة بما يسهم في تحسين جودة الحياة لمرضى السكتة الدماغية. الخامس، يؤكد المؤتمر على تفعيل الرعاية الصحية عن بعد في علاج ومتابعة مرضى السكتة الدماغية وتقديم الإرشادات الصحية والنصائح العلاجية اللازمة لهم في منازلهم ودعمهم في ممارسة حياتهم اليومية بشكل آمن وفعال. السادس، يدعو المؤتمر إلى إشراك المختصين في تقييم الإدراك المعرفي لمرضى السكتة الدماغية والعمل على تحديث وتطوير نماذج التقييم المعتمدة بما يتوافق مع أحدث الممارسات العلمية والمعايير العلمية والعالمية، وسوف يكون أول تقييم معرفي لمرضى السكتة الدماغية على مستوى الوطن العربي يصدر من مختصين في مجال السكتة الدماغية في هذا المؤتمر الطبي. سوف تعلن جميع التوصيات باللغتين، اللغة العربية والإنجليزية، وترفع للجهات المختصة بذلك. تمنياتي لكم بالتوفيق، والسلام عليكم ورحمة الله وبركاته.
شكرا لجميع المتحدثين وشكرا لجميع المستمعين. في نهاية هذا المؤتمر نشكر الجميع وندعوكم لتناول طعام الغداء. السلام عليكم ورحمة الله وبركاته.